modified Blalock-Taussig Shunt 1983, and objective of this study to study mortality rate, survival, and factor effect to outcome. Methodology is a retrospective chart review in who underwent a modified Blalock-Taussig Shunt in 10 years from January 2005 to December 2015. Primary outcome is in hospital mortality, and secondary outcome is survival rate, complication, and risk factor. In results show in this study is 144, mainly is a male 56%, and mean age was 1.8 years. The body weight at surgery divided for 4 groups. In first group, body weight less than 3 kg is about 20%, and T to T.5 kg is 12%, and T.5 to 5 kg is 18%, and more than 5 kg is 49%, and most of the patients no associated syndromic disease. The top 3 diagnosis was Tetralogy of Fallot, pulmonary atresia with ventricular septal defect, and transposition of the gate vessel with pulmonary stenosis. The shunt size was 5 mm in 35% and 4 mm in 33%. And 64% of patients was approved by light thoracotomy. The mean ICU stay was 12 days and mean hospital stay was 25 days. Pneumonia was 30% of patients, and septic and septic shock was a secondary complication was 15%, and cardiac arrest was 8%. Shunt-related complication was shunt obstruction about 10% and inadequate shunt about 8%. Mean time interval to secondary surgery was 57 months. Mortality outcome in hospital mortality was about 14%, and 57% of patients was underwent to secondary repair. The survival outcome is median survival time about 7.7 years, and 1 year, 3 year, 5 year survival was 72%, 61%, 52%, and 46%. This is a Kaplan-Meier graph to show survival outcome. Univariate analysis was many factor significant statistics such as age, body weight more than 5 kg, diagnosis of Tetralogy of Fallot, hypoplastic left heart shunt size, and heparin and ASA post-op and complication. This graph is show the univariate analysis, but in multivariate analysis we found just only 2 factors have significantly was body weight more than 5 kg and cardiac arrest. This is a graph to show the multivariate analysis. Discussion in hospital mortality of this study was 14.5, and secondary rate repair is 58%, and the only 2 of risk factor is significant is cardiac arrest with hazard ratio 4.2 and body weight more than 5 kg with hazard ratio 0.2. And conclusion in hospital mortality was 14.5%, and cardiac arrest and body weight more than 5 kg were the factor of affect mortality, and low rate of the secondary surgery which have to further study. The limitation is a retrospective study, small sample size, and no standard long-term complication, incomplete medical record, and survival outcome not truly affect the modified Blalock-Taussig shunt. Thank you.
Any questions from the floor? Yeah.
Did the
Yes, it affect because of some disease, good prognostic outcome if we do modified Blalock-Taussig shunt, but not significant, not statistically significant, such as death and hypoplastic left heart disease.
And how your results compare to the all over the world? And how can you translate your results into your practice?
Yes, and in primary outcome, my study was similar to all over the world, but in secondary rate repair, this study will lower rate than other study, but it may be because of the economic of the patient, and we have to do more study and do the protocol to follow up next time. Thank you.
May I ask you one question? You said your primary question is mortality rate, right?
Yes.
So because the patient has many variety of the diseases, and this mortality reflects your overall treatment or just only mortality from the Blalock-Taussig shunt?
It's overall mortality.
So it doesn't mean that it's not your Blalock-Taussig shunt mortality, right?
Yeah.
Okay.
I have some question to because you use the logistic regression, right? And you use the univariate and multivariate. I see your univariate, and they are all statistically significant. How did you choose to do the multivariated?
We use if univariate significant, we will bring it to calculate multivariate.
Yes, but when you use your univariated, it's all significant. But when you come to your multivariate, it's reduced just only some variables.
Yeah.
Can you tell me why?
I think maybe it's small sample size and it have to not affect if we calculate in multivariate.
In the all patient, are you analyze about the antiplatelet or anticoagulant? Is it effect to the result?
No, it's significant in univariate, but if we calculate in multivariate, it's not significant.
Did you do the subgroup analysis? What is the risk factor for the shunt thrombosis? How many percent for the shunt thrombosis?
Shunt thrombosis about 10%.
10%.
Yes.
Any
but not have this study not focus in shunt thrombosis, so
okay. Yes.
it's not out of my study.
Any more questions from the floor? Okay, very good, very nice.
Thank you.
So during the committee scoring, we are moving for the second topics, second presentations by Dr. Virawit from
Central Chest Institute of Thailand.
Okay.
Good morning, everybody. My name is Dr. Virawit from Central Chest Institute of Thailand. Today, I would like to present my research and comparison of operative outcome between single pulse and multiple pulse video assist thoracoscopic surgery for primary spontaneous pneumothorax. Primary spontaneous pneumothorax is the spontaneous pneumothorax occurring in patients without prior known underlying lung disease. In the past, open thoracotomy is treatment of choice for primary spontaneous pneumothorax and decreased recurrence rate. After that, mini-thoracotomy was used for treatment primary spontaneous pneumothorax and decreased post-operative pain. Now, multiple part VATS, T-part VATS, or two-part VATS is used to treat spontaneous pneumothorax because less possibly pain than thoracotomy and decreased neurologic outcome. And then, single part VATS is introduced and more used for practice primary spontaneous pneumothorax. And in 2015, academic review and meta-analysis report that single part VATS was less operative pain compared with T-part VATS and safe and decreased scar. My objective is to compare positive outcome between single part and multiple part video assist thoracoscopic surgery in primary spontaneous pneumothorax and methodology. And my study design is retrospective, and my institute initial single part VATS at the 20 and 15. Data collection between January to 20 and 15 to February 20 and 19. Inclusion criteria is primary spontaneous pneumothorax more than 15-year-old, operation single part with multiple part. Exclusion criteria is secondary pneumothorax. And the surgical technique is single part VATS is about 3 cm utility part as a fifth anterior CG line. After operation, 2 chest drain was inserted and control pain with morphine and paracetamol. And the multiple part VATS is 3 cm utility part at the fifth anterior CG line, 1 cm camera part at the 7th mid-CG line. If a 3 part, the third part as the 6th posterior CG line. After operation, 2 drain was inserted and control pain with morphine and paracetamol too. The total 99 patients in the first group single part VATS has 44 patients, and the multiple VATS has 55 patients. The primary outcome is post-operative pain as immediate post-op and post-operative the first day, second day, third day, and 7th day. And the first visit, mean follow-up, so 94 days. And the secondary outcome is operative time, intraoperative blood loss, length of hospital stay, post-operative complication, duration of ICD, and post-operative recurrence at 6 months. I use pneumoral pain rating scale for evaluate post-operative pain. And my statistic is the student retest, chi-square, Myasthenia test, and Fisher exact test. It's my results. The peer-reviewed data show age, gender, weight, height, BMI, smoker, albumin in the both group is not significant difference in the both group. And the diagnosis in the both group is not significant. In the unilateral pneumothorax in the single part VATS has 93.2% and multiple part has 94.5%. In the bilateral pneumothorax and the single part VATS group has the 6.8% and multiple part group has 5.5%. The operation unilateral VATS at the single part in the single part group has 95.5% and multiple part group has 94.5%. And bilateral VATS in the single part group has 4.5% and the multiple part group has 5.5%. This is primary outcome is post-operative pain. This graph show in the immediate post-op, second day post-op, third day post-op, and 7th day post-op is not significant differentiation. But in the first day post-operative, at the single part group has less positive pain more than the multiple part group significantly. In the first visit, post-operative at the both group is not significant differentiation. This graph shows operative time in the single part group less than multiple part group is significant. The single part group used 125 minutes, and the multiple part group use 157 minutes, and differentiation significant. And the hospital stay and perioperative blood loss in the both group is not significant differentiate in both hospital stay and perioperative blood loss. The chest tube removal in the DN 1 and DN 2 in the both group is not differentiation significantly. The communication at the single part and multiple part is not significant differentially. And in the single part group has the positive bleeding and wound infection, and the multiple part group has a positive air leaks and positive empyema thoracis. And the post-operative recurrence in 6 months in the both group is not significant differentiation. And my conclusion is this research is single part VATS is not inferior to multiple part VATS for treatment primary spontaneous pneumothorax, and in my statistics, this single part VATS is safe, shorter bleed time, and less post-operative pain more than multiple part VATS. Thank you.
Is any question from the floor? Yes.
Difference between operator, surgeon, because as you can see from your operative time, the single part, which is more technical challenging, have less operative time.
Single part, less operative time.
Yes, and that may be explained because of the surgeon, the performer of the operator, and it's a big confounder.
I think it is a limitation of the research, because this research is not a single surgeon. It's many surgeons, including maybe resident. Yes.
So maybe the factor, maybe the resident.
Yes. Thank you.
So may I have questions? Because you said this research is retrospective, and you plan to record the pain score.
Yes.
Like day 0, day 1, day 2, day 3, day 5, day 7, or whatsoever. Is it your policy to record the pain score in the past patient?
Yes.
You have that in your record
Yes,
completely? How many % of your complete data?
Complete data is I'm not correlated complete, because some patients come back before 7 days.
Yes, understand, but in that retrospective data, did you record the pain score?
Yes.
Is your policy, hospital policy, to record the pain score?
Yes, and the nurse records at the graphic sheet, and maybe nurse knows in record about positive pain with score.
Okay.
I have just a few comments, because your study is a retrospective, right? But when you analyze your statistic, you just use only simple statistic. Your correct data is very good, but if you use a more complex statistic, like some regressions, because you compare between two groups like t-test, the t-test cannot tell us which are better, just only different, but don't tell us which are better. If you use more complex statistics, it may be better result, like an odd ratio or something that will show us single part is better.
Okay, I think it maybe in the future I will research maybe RCT is good.
Last question.
The last question. How can you apply your result in your practice? Are you going to do one part?
Yes, and in the future, maybe I improve my skill for use single port VATS for surgery.
Okay. So
Thank you.
we are moving to the next presentation. Is Dr. Siravi from Ramathipati Hospital. The prognostic value of intraoperative pleural lavage cytology as an independent prognostic factor in non-small cell lung cancer. Please.
Good morning, ladies and gentlemen. Pleural lavage cytology or PLC is a diagnostic tool that can be used to detect tumor cells. It's a simple procedure to add on to the usual operation and has been reported to be useful in predicting prognosis and not in non-small cell lung cancer patients. The primary objective of this study is to demonstrate that intraoperative pleural lavage cytology has a significant role in predicting clinical outcome in these patients. We had retrospectively reviewed from January 2012 to December 2016 all patients with non-small cell lung cancer who underwent lung surgery and intraoperative lavage in Ramatipidi Hospital were included. We exclude some patients who has preoperative pleural effusion and some patients that data has been lost. Intraoperative pleural lavage was performed 3 times for each patient. The first one was performed immediate after the thoracotomy prior to any further manipulation, and the second one was performed after complete the operation. The third one was performed after wash the pleural cavity with 5,000 ml of normal saline solution. We collected 500 ml of pleural lavage for each specimen and take cytologic report positive for malignancy or presenting of a typical cell as positive. There were total 178 patients. 20 of them has pleural lavage cytology positive. Survival rate and recurrence rate were compared between 2 groups. Continuous data were reported at mean with standard deviation or median with interquartile range and compared by the independent t-test or Mann-Whitney U test. Categorical variables were presented and analyzed by chi-square or Fisher-exact test. Survival rate and recurrence rate were analyzed by Kaplan-Meier method and evaluated by log-rank test. We defined the statistically significant at p-value lower than 0.05. These are patient baseline characteristics in intraoperative pleural lavage cytology negative and positive groups, which are quite similar in both groups. What are different between 2 groups are the visceral pleural invasion and lymph node positive for malignancy, which seem to be higher in the cytopositive group. Cytology positive groups seem to have a higher post-operative staging correlate with the previous slide. These are patient characteristics in non-recurrent and recurrent or metastatic group. We noted that most of the baseline characteristics such as age, gender, BMI, or underlying disease were similar in both groups. Patients with PLC1 positive had higher recurrent or metastatic rate than in PLC1 negative group, with p-value less than 0.05 and the hazard ratio as shown on the right-hand side of the table. Same as previous slide, patients with PLC2 positive had higher recurrent metastatic or metastatic rate than in PLC2 negative group. And patients with PLC positive also had higher recurrent rate than in PLC3 positive negative group. These are patients with positive PLC whichever specimen 1, 2, or 3 also have a significant higher recurrent rate than in the negative group. This graph shows a percent of recurrent and metastatic rate in patients with positive PLC compared to in negative PLC group. The brown one is percent recurrent in positive group and the green one is the negative group divided by order of specimens. This slide is a graph of recurrent or metastatic rate by cytology. The green line in this graph is patient with negative PLC and the blue line is patient with positive PLC. As you can see, patient with positive intraoperative pleural lavage cytology has a significantly higher recurrent or metastatic rate. This graph also shows recurrent and metastatic rate by cytology similar to the previous one but divided by each specimen. The solid line represents PLC positive patient. Patient with specimen 1 positive had a higher recurrent rate compared to specimen 2 and specimen 3 positive. Other factors that seem to have impact on recurrent and metastatic rate is vascular invasion, visceral pleural invasion, and lymph node positive for malignancy. Patients with higher post-operative staging had a higher recurrent or metastatic rate. Turning our attention now to the survival rate. Patients in positive PLC group had a statistically significant decrease in survival rate compared to those in negative group. This slide is focused on specimen 1. Same result go for specimen 2. And we got the similar result for specimen 3. The overall cytologic result compared between two groups. The negative PLC group has a statistically significant better survival rate. To be easier to picture what I've said, this is the graph show percent of dead patient divided by cytologic result. The brown one is percent dead in positive group and the green one is percent dead in negative groups. This graph shows the survival rate by cytology. The blue line is patient with positive PLC and the green line is patient in negative PLC group, which have better survival rate. The solid line in this graph represents PLC positive patients. The other factors that have role in decreasing survival rate are longer length of hospital stay, vascular invasion, visceral pleural invasion, and lymph node positive for malignancy. A higher post-operative staging also have significantly decreasing in survival rate. In subgroup analysis in patients with post-operative stage 1A and 1B, compare the recurrent rate between patients with positive PLC and negative PLC are as shown. Patients in PLC positive group had a higher recurrent rate in both stages. Patients in post-operative stage 1B with cytologic result positive have worse survival rate compared to the negative group. In conclusion, this study demonstrates that intraoperative pleural lavage cytology had a significant role as a predicting prognostic factor in non-small cell lung cancer patients. Patients with positive intraoperative pleural lavage cytology has statistically significant for increasing recurrent and decreasing in survival rate. Intraoperative PLC is a simple procedure that can add on to your usual operation, which could provide some useful information for predicting disease progression and treatment planning. Thank you.
Any questions? Yeah, please.
So about your research, that can you give a definition to the words metastasis? Because some of the patients may have N1 and some of the patients may have N2. And what about the application of the PLC? If the patient has a positive PLC, which may be N2, can I stop the operation and just leave the patients to go on the chemotherapy?
Sorry, if the patient has positive
PLC, can you define the words metastasis? Does it include the N2 stage in your study?
No, metastasis means like the recurrence of the tumor in other sites apart from the stump of the tumor. It's not included into. Staging of you mean the pre-op staging, right? Clinical staging is we have like from stage 1A to stage 3A, but yes, not include into. But I have to admit that not every case we have the lymph node, not every case that we have the complete staging before go to the operation. We didn't do the PET scan, and some of the cases we didn't do the PET scan, and we don't do the lymph node biopsy. So I'm not so sure about the pre-op staging, that is correct or not. Post-operation, the PLC2 we check just immediate after the operation. I have that number, but I don't have it in hand right now. It's around 2 or 3 cases. That negative in PLC1 and positive in PLC2 and 3. Yes, not much.
Yes, I have a few questions. First, you said positive lymph node is increasing the rate of the PLC, right? Yeah, but
Yes,
yes. And that is a N1 or N2 or any N?
at the end.
Any N. Even the N1 increasing?
The pitfall of this study is that I didn't differentiate the N1 and N2.
Okay. The second question is, you didn't compare the PLC positive risk of recurrent and death compared to the standard staging TNM that we already use. Does it any impact, your paper, any impact to change or anything to the standard TNM classification?
We compare that the higher state is all right. We do the subgroup analysis for the first state 1A and 1B to see if in that group is different if the patient has pleural Lavage cytology positive and negative.
Okay. Oh, yes, please, sir.
My name is Olin from New Zealand. Excellent presentation. It's a little bit busy slide, so it's a bit hard to follow. My question is simple, actually. If you find the weakness at the time of first lavage, by definition, that just becomes metastatic disease. That just becomes MT4. So the question, I think, is perhaps the same with the first discussant. Maybe the operation should have been stopped if the first specimen is positive.
Thank you.
Yes. Okay, moving for the next presenter.
Next business is post-lobectomy pulmonary function in video-assisted thoracoscopic surgery compared with minimal thoracoscopic surgery by Dr. Blalock. Please.
Good morning, Professor, Chairman, and everybody. I'm Blalock-Taussig from King Chulalongkorn Hospital. I will present my study, post-lobectomy pulmonary function in video-assisted thoracoscopic surgery compared with mini-thoracotomy surgery. Background of this study. As we know, open thoracotomy is the standard for lobectomy. In the past, incision may be 20 to 30 centimeters. At the present, incision is reduced to 5 to 7 centimeters, as we call mini-thoracotomy. Since 1990, video-assisted thoracoscopic surgery is acquired widespread favor with the rapid development because of minimal invasive. It shortens skin incision, less pain, and from many studies, the oncological outcome of VATS is comparable to open thoracotomy. However, in the aspect of pulmonary function, it is unclear whether post-operative pulmonary function after VATS lobectomy is better than after mini-thoracotomy lobectomy. Yes, this become research question that video-assisted thoracoscopic surgery VATS had better post-operative pulmonary function than mini-thoracotomy surgery. Okay. This study was designed to prospective study non-randomized controlled trials, and the study was conducted between April to October 2019. Okay. At the King Chulalongkorn Hospital, there are 2 thoracic surgeons. First surgeon dedicated to VATS group and second surgeon dedicated to thoracotomy group. If the patient walk into first surgeon, they are allocated to VATS group. In another way, if the patient walk into a second surgeon, they are allocated to mini-thoracotomy group. For inclusion criteria, we include our patient 18 to 80 year old undergo VATS or mini-thoracotomy lobectomy and never lung surgery before. Okay. And exclusion criteria are emergency case and patients who contraindicate to pulmonary function test, example, thoracic aortic aneurysm, cerebral aneurysm, recent MI, recent stroke, or uncontrolled hypertension. And non-anatomical resection, example, weight resection, also was excluded. Bedside pulmonary function test was performed using chest scarf, HSI 105, 1 day per pre-operative, 3 days post-operative, and 3 months post-operative. But lobectomy were performed using a single port endoscopic technique 3 to 5 centimeter skin incision, 5 intercostal space, and space by silicone rubber detector. Yeah. And while mini-thoracotomy, lobectomy were performed, so 5 to 7 centimeter skin incision, 5 intercostal space, space by metallic lip detector. Our patients were pain controlled by intraoperative intercostal nurse block and post-operative pain controlled by PCA fentanyl. And primary outcome for this study is the pulmonary function. And secondary outcome consists of operative time, within a month, length of hospital stay, and hospital cost. Sample size calculation, we use this equation for 2 independent groups. So N per group is about 15. In general, post-operative pulmonary function depends on the amount of resected segment and predicted post-operative FVC and FV1 is correlated with the proportion of segment that remain. Normally, post-operative pulmonary function cannot directly comparable between groups because of variation of lobe. For comparison of pulmonary function with other bias of lobe location, percent predicted post-operative value, percent PPO FVC or percent PPO FE1 are compared between groups. And for systemic early reduction, we calibrate pulmonary function test equipment before establish the study. Okay, and go to the result. Yeah, total 33 patients were low. 1 patient was excluded from each group because of advanced CA state. There are 17 patients in VATS group and 14 patients in mini-thoracotomy group, and 1 patient dry between follow-up in VATS group. Okay, for baseline characteristic, either gender, mean age, BMI, tumor size, or resected segment per person are not different between both groups. The operative pulmonary function shown that either FVC, FE1, PPO FVC, or PPO FE1 are not different between both groups. At 3-day post-operative, percent PPO FVC of VATS group is 10 to higher than mini-thoracotomy group, however, no statistic significantly. Percent PPO FV1 of VATS group is about 13% higher than mini-thoracotomy group significantly. Okay. Nevertheless, at the 3 months post-operatively, no significantly different in percent PPO FVC or percent PPO FV1 between both groups. Left side is the FVC and right side is the FV1. We will see that the average FEV1 in mini-thoracotomy group is decreased more than VATS group. Okay. And for the secondary outcome, the mean incision length in VATS group is about 4.5 centimeters, shorter than 6 centimeters of mini-thoracotomy group significantly. Bleeding amount had no significantly different between both groups. Same as operative time had no significantly different between both groups. VATS group show shortened length of hospital stay significantly 4 days compared with 6 days of mini-thoracotomy group. Okay. However, VATS lobectomy is of really higher hospital cost significantly, about 50,000 baht higher than mini-thoracotomy. For the discussion, FE1 is represent the power of expiration that it inversely correlates with postoperative pain, while FVCF is represent the volume of lung. Limited decrease from pain can also affect this volume. So pain is affect the pulmonary function at a short period of time. Okay. For the limitation of this study, the first thing that this study is not randomized controlled trial. There it may be a selection bias. And another thing is small sample size, and we need to do more sample size in the future. Okay. For the conclusion, patients who undergo VATS lobectomy had better pulmonary function at 3-day post-operative, whereas the 3-month post-operative had no significantly different, whereas give benefit in better cosmetic skin and shorter length of hospital stay. However, mini-thoracotomy is an option for lung resection surgery. Between amount and operative time is not different. Meanwhile, mini-thoracotomy was of really safe hospital cost significantly. Okay, thank you.
Thank you for your good presentation. Is there any question from the floor? So I have a few questions. When you perform the mini-thoracotomy, in my still, sometimes we use the video acid to use the mini-thoracotomy to do the mini and use the VATS scope to help to see the highlight or something. Did you use this technique with it?
No.
Just
It's
only mini-thoracotomy?
Just, yeah, direct vision from mini-thoracotomy. Oh, no, from the staple cost. You mean in the VAT group? Additional costs include from the scroll that and sample. That are these two things that I think that it can increase the cost.
Yes. As you mentioned that pain can affect the outcome, you measure the pain score in both groups?
Okay.
Slide
Can you show?
Additional
data and correct from the patient is the pain score. Again, at the first row is the first day pain score, and second row is the second pain score, and the third row is the third day. Okay, we show that in the lobectomy group, pain score is lower than in the mini-thoracotomy group, especially in the third day and significantly. Yes, so I think when the patient pain, it cannot deep breath and don't have the floor to blow the pulmonary function. Yeah.
But in both groups, you didn't control pain in the same.
Yes, in the same. And in terms of we will use the internal costal nerve block. Post-op pain we control by fentanyl PCA. Yeah.
Both procedure is not pain different, is it? Because the pain control is different.
It's not exactly different because when you the patient controlled by PCA will push the drugs, okay, the medication, okay, and when the pulmonary function, we have the effort, so more pain in the, I think more pain in mini-thoracotomy group. Yes. Normally about 2 or 3 days. Yes. Yes. Yes.
Day 3, right?
Day 3, yeah.
Okay. Any more questions? Okay. Thank you.
Okay. Thank you very much.
So we go to the next study. The next study presents from Dr. Chavivat from Thamangkut Hospital about the comparison of change of follicular helper cell level in Myasthenia gravis patient undergoing thymectomy and medical treatment. Please.
Good morning, Chairman, Co-Chairman, and ladies and gentlemen. My name is Chavivat Golit from Division Cardiovascular and Thoracic Surgery, Pharmacology Hospital. Today, I would like to present the study cooperative with Division of Allergy and Clinical Immunology from Chulalongkorn University. The comparison of change in follicular helper cell level in Myasthenia gravis patient undergoing thymectomy and medical treatment. Myasthenia gravis is a long-term neuromuscular disease that leads to varying degrees of skeletal muscle weakness that decrease quality of life and working ability. And thymectomy is a procedure for myasthenia gravis patients for a long time and has a significant benefit but variable effect. The factor that determine the outcome of thymectomy in patients with MG is still unclear. Although many studies found that T follicular helper cell increase in MG patients, but relation of actual level and outcome thymectomy is obscure. So the objective is to determine the main cytology factor that lead to good outcome of thymectomy in MG patients, and whether T follicular helper cell could be used as a predictor for good clinical outcome. Our methodology and study design we have a prospective comparative study of MGFA class 2 at least and have not been receiving chemotherapy or intravenous immunoglobulin patient. The population we use all patients who diagnosed myasthenia gravis with anti-acetylcholine receptor antibody above 1 nanomole per liter by neurologist in Pharmacology Hospital and treated with medication for 1 year within 2017 to 2019. Inclusion criteria, we study the patient who diagnosed MG by neurologist and anti-acetylcholine receptor antibody above 1 nanomole per liter patient who received medication for 1 year. Exclusion criteria, we exclude patient who receives intravenous immunoglobulin and have other autoimmune disease, or patient who receive chemotherapy or other immunosuppressive drug other than penicillin, and pregnancy patient will be also excluded. We classify patients into 2 groups. The first one is the group that treat with medication alone, and the other one is the group who cannot tolerate clinical or drug side effect and underwent median sternotomy and thymectomy. All patients were followed up for 1 year, and peripheral blood molecular cell was collected before and after treatment. This diagram will show that all patients will treated with medication for 1 year when 35 patients, and we follow up for before separate the treatment. We found that 7 patients have receiving IVIG, so we exclude the 7 patients away. So we divide in 2 groups. One group is 13 patients continue medication, and the other group underwent thymectomy. In that time, we collect first PBMC, then follow up clinical for 1 year after the thymectomy, and we collect the second one. We use double-blind cross-label sample frozen PBMC and analyze the assay with phenotypic staining and analyzed by flow cytometry. The first one, we analyze the B cell getting strategy. We use lymphocyte, B cell, IgG, IgD, plasma blast, transitional B cell, and regular B cells. Another one, we use T cell getting strategy. And the cell we use is lymphocyte, T cell, regular T cell, T follicular helper cell, natural killer cell, and CD8 T cell. The result. Demographic data, we have 13 medication group and 15 patients in thymectomy group, and overall demographic data is no significant difference. The most of patient pathology from thymectomy was thymic hyperplasia. After the treatment, we use MGFA post-intervention status, and we found that 3 patients from thymectomy has complete surgical remission, 3 patients from thymectomy has pharmacological remission, and the other is clinical minimal manifestation at MM2, MM3, and from the medication group, no clinical improvement. This table will show that immunological factor that we found, the comparison between thymectomy and medication group. We found that mature T cell IgG was significantly increased in thymectomy group. Also, the CD4 and CD8 was interesting result. We found that normal people will have CD4, CD8 ratio is above 1, but in MG patient, both groups will have the reverse ratio, that CD4, CD8 ratio is less than 1. Another table will show that the result comparison between before and after thymectomy. we will see that the lymphocyte level of the thymectomy group, after thymectomy, the lymphocyte level will increase significantly along with plasma blast. But T follicular helper cell with regular B cell decrease significantly. The last table we show that clinical outcome we divide into two groups. The first group is the patient after surgery has no clinical of MG, and the other group is still clinical MG. We found that the T follicular helper cell did not show significantly anything, but plasma blast level and natural killer cell before surgery have significantly different. So in conclusion, MG patients have reverse CD4 CD8 ratio both and before and after thymectomy. That means thymectomy can relieve clinical MG but cannot resolve the abnormal autoimmune system of the patient. And regular B cell, that suppressed T cell was also decreased because T follicular helper cell was decreased. T follicular helper cell was significantly decreased after thymectomy in MG patient, but cannot be used as predictor for clinical outcome. And we found that the inserting immunological factor that can predict the clinical outcome is plasma blast and NK cell. Thank you.
Is there any question from the floor?
What is the clinical application from the result of this study?
We use Myasthenia Gravis Federation of America post-intervention status to identify the clinical of every patient, and we divide into group that this is MGFA post-intervention status. We divide to medication and after intervention. The first one is complete stable remission. That means this patient group had no symptom and sign of MG for at least 1 year that we follow up and did not have to use the drug. The second is pharmacologic remission. This patient has same criteria for complete stable remission, but take some therapy for MG. That means he not have clinical of MG, but have some penicillin prescribed from neurologist. This group is no clinical MG. The other group is minimal manifestation. That means this group no symptom of functional limitation from MG, but has some weakness. That means this group will have minimal clinical of MG. That's divided into MM2, M1, M3 as a table. And this group is the worst one. It's change in status. Change in status not mean improve in clinical, but improve in medication. That means it can reduce the medication that patient takes, but did not improve the clinical of patient.
I think it's what is the question that Ajahn Sompop asks is easy. Does any blood test change the practice of you?
Is the T follicular cell that we study is lower in after thymectomy, but cannot predict the outcome with such as this patient will underwent thymectomy and will be good or will be the same as before thymectomy. But we found that the level of natural killer cell and plasma bath, if this cell has high level before surgery, it means after surgery, this patient group will have the good outcome of thymectomy.
Okay. So we ran out of time, so we move to the next paper.
Thank you.
The next paper is from Dr. Shanyapat from the Sriran Hospital. The study is about the efficacy of continuous split tablets Warfarin compared to the split rate whole tablet Warfarin. It's a prelim report of the randomized control trial. Please.
Good morning, Mr. Chairman and everybody. I'm sure the most of you have experienced the Warfarin patients and managed the Warfarin patient. According to the pharmacokinetic and pharmacodynamic of Warfarin, Warfarin needs time to achieve steady therapeutic state with long half-life and slow, effective so the weekly dose is considered for prescription. Achieving the therapeutic dose, Warfarin is provided in many methods, depends on the local viable pills and patient comfort. You may prescribe in split tablet or regular whole tablet, alternate day with whole tablet or combined. This study was designed to examine the efficacy and effectiveness of Warfarin prescription with tablet splitting and alternative day whole tablet. Whether it's better to have no drug loss from tablet splitting. The interesting outcome is TTR, or time in therapeutic range, that is widely used to measure the quality of Warfarin therapy. TTR have typically been accessed by the Rosendahl method, the complex equation that worldwide used in many Warfarin quality studies, where the INR is assumed to change linearly from the last INR until the INR at next check. According to serial protocol, we usually maintain the INR in range of 2 to 3, and the TTR indicate the days with Warfarin in range over the total day Warfarin use. We set the pre-study survey in cardiothoracic department Warfarin clinic. From 102 patients, we found about 1/3 were on same daily dose tablet splitting regimen. Only 11.7% are on alternate day with whole tablet regimen. In order to decrease the contamination and to verify the effect of prescription, we focus on the alternative day with whole tablet and the same daily dose split tablet. The TTR is seen to be better in the whole tablet regimen. So the study was created with this hypothesis. Whole tablet alternative day dosing is more effective than split tablet same daily dosing in INR maintenance. The prospective randomized control trial conducted on January 2018 to June 2019. The eligible patients include the patient in cardiothoracic Warfarin clinic were able to maintain the therapeutic INR level more than 6 months with the specific weekly dose at the protocol. Those patients were asked for protocol adherence for 6 weeks follow-up period for 6 months. If they need to hold Warfarin due to any reasons, they will be accrued from the study. The sample size calculation was performed with superior hypothesis. The accepted superior hypothesis is 0.2 and p-value less than 0.05 is significant. The effect size was calculated based on the pre-study survey. The sample size is 30 in each group and 10% was at for lost follow-up compensation. The specific dose is rated as the table. As these weekly doses, we can provide warfarin with both regimens, and the prescription protocol was designed at the table. 80 eligible patients were asked for protocol consent. 46 patients were incapable of 6 weeks follow-up protocol. 34 included patients were randomized into 2 groups. 16 patients in alternate day whole tablet were asked for drug calendar usage, and 18 patients in speed tablet group were taught to use the pill cutter. Then they will follow the INR every 6 weeks for 6 months. If the INR was out of the therapeutic range without expandable course, the dosage was adjusted at the protocol. After 6 months, the TTR was calculated. The baseline characteristic was shown in the table. The mean age is 58 years old. There were no difference between 2 groups in indication on need of caregiver. And the dosage distribution in each group were shown in the table. The TTR in each group were calculated and shown insignificant difference among the different doses. The total mean TTR was 72.6%, 76.8% in alternate day whole tablet groups, and 68.9% in speed tablet group. The p-value is 0.41. That's in statistical significant. The secondary outcome was concentrated on the compliance and the side effect of warfarin use. There was no difference in the patient compliance in both regimens, and that there was no major bleeding event reported. But the minor bleeding is seen to be higher in the whole tablet alternative day group, but not statistically significant. Refer to the in vivo pharmacologic study. We found that only 1 to 10% achieve accuracy of the dosage with speed tablet. Another study on weight uniformity of half-tablet speeding, the dose variation exceeds acceptable range was found in more than 1/3 of the sample of half-tablet speeding warfarin. So, the American Medical Society and American Pharmacists Association oppose mandatory tablet speeding and recommend against speeding tablets that are modified release combination product, film-coated, fiber, or dose critical. Report on bleeding events depend on individual consent, so maybe increase in the alternate day whole tablet. In conclusion, the study shown trend in favor of the whole tablet alternate day regimen. However, further study is needed. Thank you.
Yes. May I have one question? You said this is a prospective randomized control trial, right?
Yes.
So it means all that 30-something patient, you randomize them. They never had the warfarin before?
No, they got the warfarin, but in specific dose. However, whether we don't mind whether which method they got the warfarin, but only in the specific dose at the protocol. We random them to get the warfarin in our method.
So they had before?
Yes, but in another method.
And
maybe
you
they got speed
reschedule
tablet.
their warfarin according the randomization, right?
Yes.
So they can have split dose before, and now they have the alternating day before.
Yes.
Split dose before and now whatsoever different.
We
After
random them, yes.
randomized. Any patient complain about and 1/4 pills?
Some patient complain, but however, they can do that.
Okay. So, and because of, with my knowledge, after your result, it seems comparable, right?
Yes.
And but your conclusion, you said the split dose is much more favor.
No, I mean whole tablet alternate day much more favor.
Oh, okay.
Yes.
Any questions? Yes. Babu.
When you decide a study, on which day you take the, the blood sample? If you give the alternative Warfarin on Sunday, which is the maximum dose, and if you take the blood on Wednesday, maybe the other is lower than the normal. On which day you decide the study?
That may be the confounder. However, we decide the study to nearly the normal life. So sometimes patient got the Warfarin on the higher dose on Sunday, and as you said that he got the blood test on Wednesday. Maybe it's the confounding factor, but it's normal life of the patient too.
Ask questions.
Thank you.
One more questions.
Sorry. As your result, there is nothing significantly statistically. But why your conclusion is you favor on the alternative day?
As we found,
nothing significant.
I said that further study needs because our study is very low volume of the patient conclude in the study. However, as we shown that the alternative, the dosing is tend to be more favorable. In INR maintenance, as the TTR calculation is higher in this group. With this low volume patient.
This study is ongoing right now because we hardly recruiting the patient, which have a stable INR, and we have to ask the patient to come very frequent during the study. So we cannot recruit enough patients. So it is underpowered right now, and we continue to do this study further, and maybe report to the meeting maybe next year.
Yeah. Next speaker is Dr. Abhishek from Rangsit Universities about the efficacy of aminophylline in preventing acute tubular damage on open coronary bypass. Use the double by RCT. Let's start.
Hello. Good morning, Chairman and everybody. Op-cap in avoided is growing, but renal failure is still a major and serious complication. So a way to improve op-cap is to prevent AKI. And aminophylline is a renal protective agent. NGAL or neutrophil gelatinase associated lipocardin is the most acceptable biomarker in cardiac surgery that can assess acute tubular damage and predict early AKI. So for this study, we want to evaluate efficacy of aminophylline in preventing acute tubular damage by measuring urine count. This is an example study that there are evidence show that in open heart surgery, aminophylline is better than Lavage in correcting intraoperative oliguria, and it can maintain post-operative GFR and can prevent AKI with number needed to treat of X in the paper of Mahado, and prevent AKI in the high-risk Kipling score group that shown in paper of Chabano. And according to Visual Jain et al., NGAL is good predictor for early AKI in op-cap. Our primary endpoint is to assess the efficacy of aminophylline in preventing acute tubular damage by measuring UNGAL. And the secondary endpoint are renal insult in terms of possible acute tubular damage, AKI, hospital stay, ICU stays, and other complications. According to Hideo et al., we define possible acute tubular damage at the cutout value of urine count of 50 nanogram per milliliter, and we use Akin criteria for diagnosis of AKI. Aminophylline act as an adenosine receptor antagonist at the nephron. At the afferent arteriole, it prevents vasoconstriction, but at the efferent arteriole, it prevents vasodilatation. And at the proximal convoluted tubule, it prevents sodium reabsorption. So it results in increasing in glomerular infiltration rate and urine output. When the normal kidney meet with the outcap as a renal insult, NGAL will release two tubular lumen in the first few cells and peak at the 4 to 6 cells. And some is reabsorbed to the bloodstream. If the renal insult persists, more tubular functional reserve is destroyed. GFR will decrease, creatinine will rise, and when the criteria is met, so diagnosis of AKI. According to the compare mean formula, calculated in this study is 13, plus 2 dropout become 15. We include elective case for OPCAP in elective case for the OPCAP in Rapid Hospital from March to November 2019 with the age of 18 to 85 years old that were informed and give us the consent. And we exclude the participants of two groups. First, who have preoperative risk of AKI, and the second, who risk when we give the aminophylline. This is four charts of the studies. 56 elective OPCAP patients were admitted, and 30 passed our criteria. One subject would select one encode seal envelope as a method of randomization. So that would by anesthesiologist team, surgeon teams, and ICU care team. And intervention solution would give to the subject before skin incision. Urine gall was collected at the immediate postoperative time point, and creatinine were collected at the 24th and 48 hours. When the perioperative data was all collected and analyzed, we found that preoperative data is similar between aminophylline and control group, except for preoperative LVEF that is significantly higher in the aminophylline group. For the intraoperative data, they are the same between two groups. And for the M results, renal insult measuring by mean urine count is lower in aminophylline group with a mean of 19. Meanwhile, for the control group with a mean of 28, but not significant. And for the renal insult in terms of possible acute tubular damage and AKI, possible acute tubular damage occur one in aminophylline group, but 4 in control group, and AKI no AKI occur in aminophylline group, but 2 in control group. However, it's not really significant. For the arrhythmia, other adverse events, ICU stay, hospital stays, are the same between two groups. In summary, baseline characteristics are similar between two groups except for preoperative LVEF. And renal insult in terms of urine gout, possible acute tubular damage, AKIs, are all favor aminophylline group, but not significant. So to answer our objective, we can conclude that aminophylline seem to prevent acute tubular damage, but not significant different compared to the placebo. However, aminophylline is safe in OPCAP patients. It results in less acute tubular damage, AKI, but not still reach the significance. Due to this study have small sample size as a limitation, further larger study may be needed. In the previous study showed that the mean urine gout in the OPCAP patients is about 100 in the OPCAP and about 120 in the on-pump CBG. And the paper of visual chain in mean urine gout in the AKI group is about 400, and in the non-AKI group about 35. So when look for the our results, the urine gout of our result seem to less, very less than the previous study. So after we discuss with things, the possibilities maybe first is our small n, second is low risk of the type of surgery, and the third is maybe we only include the low Kiflen score patients.
Okay, time's out.
Okay, finish.
Any questions from the floor? So, sir, I may miss this, but because how often the incidence of AKI in your OPCAP patients, in your population, I mean in overall populations?
For the studies,
I mean, is it a big incident that you pick that is a problem to get this problem to be fixed or to find out what is the answers? How big is the incidence of AKI in OPCAP population in your institute?
We not include our total OPCAP to see the incident yet, but from the practice we found that many patients that post-operative have the creatinine risings, and the paper say that its incidence is about 8%.
8%.
Yes, 8%.
Any questions from the floor more? Okay, we move to the next session.
Thank you.
Okay, the next session is from Dr. Praveen from the Chiang Mai Universities. The topic is about the outcome of modified hemofiltration during cardiopulmonary bypass surgery in moderate high Kiflen clinic score. Is a randomized control trial. Please.
Thank you very much, Chairman and Co-Chairman. My name is Praveen from the Chiang Mai University's Hospital. I would like to talk about the background. The first, patients who undergo on-pump CABG have increased risk of the develop major organ dysfunction, and after on-pump CABG may occur acute kidney injury or AKI up to the 30%. And many techniques have been developed to manage perioperative kidney impairment, such as extracorporeal leukodepletion and hemofiltration during on-hand alarm machines, although the extent of clinical efficacy is not clear. So in this study, we'll compare the postoperative renal impairment to look the serum creatinine and creatinine equivalent diagnosed by AKI critical criteria with and without using intraoperative hemofiltration during on-pump CABG. Then it was a prospective randomized control trial study. The patient who diagnosed coronary artery disease will schedule to undergo an on-pump CABG. For the predictive score to detect patients who had a preoperative renal impairment, I used the equivalent clinic score by Taka. This model can predict AKI after cardiac surgery. And this table shows the risk score are converted to estimated risk of dialysis with the following conversion. So if patient has score greater than or equal to 6 points, they had risk of dialysis up to 7.8%. That's a 4-time risk compared with the 5 points that you see the slide. For the postoperative AKI is indicated by critical criteria from state 1 in serum creatinine. And the sampling and randomization is used by block of 4 and divided 2 groups as a chrome MAF group and no MAF group. For the modified ultrafiltration or MAF, either performed before the cannulation, and in MAF group, it took about 10 minutes to filter the blood. And during the filter, the volume status and blood pressure was monitoring. And this study used the filter was the Outcome Max HF19. It contains the polyurethane sulfone and polyurethane. It can filter the low molecular weight less than 60,000 Daltons, such as the Cytokine, tumor necrosis factor, or interleukin. My primary outcome is excess postoperative AKI for critical criteria in postoperative day 3, and change of serum creatinine and creatinine equivalent. And the statistic is estimated the threshold of significant use the probability of 0.05, and comparison of serum creatinine and creatinine equivalent between groups with the repeated measure mixed model analysis. The diagram shows all patients in this. The data collected at Maharana Consumer Hospital between October 2017 to September 2019. And the inclusion and exclusion criteria as shown on the left side of the slide. The patients scheduled for CABG total 220 patients, and after selection from the criteria, just have the 40 patients from randomization. All the patient had informed consent. For the below this slide, the MAF group was left 17 patients from a lot of data. Let's go to the result. The table 1 shows the general patient characteristic data. There was significant between groups in Euroscore 2 and serum creatinine form significant by change. Also, this slide is underlying disease, the COPD is significant by change too. In the table 2 shows the intraoperative clinical outcomes, and the status of surgery was significant between groups from the significant by change. And the postoperative clinical outcomes for the postoperative AKIs, there was no significant between groups, but the creatinine current as 2 weeks follow-up was significant. This is the figure 1 shows the serum creatinine change over time comparing between 2 groups, and the mean serum creatinine in MAF was not different from those no MAF groups. This analyzed by repeated measure with mixed model, adjusted by baseline creatinine, Euroscore 2, COPD, and type of surgery. As a figure 2 is comparing creatinine current over time between 2 groups. For the MAFs and no MAFs group was not different too. So the discussion, the primary outcome was not significant difference of postoperative AKI by critical criteria. And the change of serum creatinine and creatinine current was not significant of difference between groups. For the secondary outcome in MAF group, patient didn't require the hemodialysis after on-pump CABG, and there was no 30 days mortality. In the baseline, serum creatinine, Euroscore 2, COPD, and type of surgery, as the diagram shows, were significant difference. But difference between groups could occur due to change. My conclusion and the change of serum creatinine or creatinine current was not different between 2 groups, and a further study with multicenter trial or larger sample size are warranted. Thank you very much.
I have a question.
T first.
นี่นะครับเปิดสไลด์ไว้ทุกคนเลยกันนะครับ
I have question about your
เปิดหน้าแรกด้วยครับ
conduction of your study, the diagram.
Yep.
You
Diagram.
enroll total of 40 patients, right?
Yeah.
And you analyze the patient in the left-hand group, hemofiltration group, only 17. So you exclude the patient that you cannot completely collect data
Yes.
out of study, and you didn't compare the whole 20 patient in baseline characteristic. Why did you do that? Why you exclude 3 patients from?
Oh yes. The data is about intraoperative data, such as when we use the ongoing the cardiopulmonary bypass, we use the diagram data from the perfusionist, such as when we use the aortic cross-cam time, cardiopulmonary bypass time, or what's the type of the about the surgery. We the surgery surgeon in my center is many surgeons. So we different from the cardio bypass time, aortic cross-cam, or the data of patient. So I think it's when the data collection is lot in the intraoperative, I think it's not fair to include patient to analyze the both groups. So I think it's have to cut this patient out. But then after I collect, it's not complete. I think it's when analyzed together, it's not fair. Allow the intraoperative outcome and post-op.
But that you can break the effect of randomization, because you will lose some. That may explain why the baseline is not.
Yeah, because it's equal the both side, right?
And did you perform sensitivity analysis to compare if you include all 20 patients in the analysis, whether the result is show to be the same or not?
When I include the baseline,
Yes,
is the
all 20.
yes.
This will be the same like this.
Yes, as the minimal change is not, but the same significant like this.
Okay.
Could you please go to back for the first? May I comment a little bit about your research, the headline?
Headline, right?
Yeah, the first minute. So is the Cleveland Clinic score? Is this always for the kidney result? Always?
You mean the Cleveland Clinic score, right?
Yeah.
It's after cardiac surgery. It's the score is predict after cardiac surgery.
This is only the kidney result for the Cleveland Clinic score. So for your names, or when the first time I read it,
Yep.
go back. So it doesn't seem what is the primary outcome. You said the outcome is the renal outcome only. And the second one is your population in your headline is cardiopulmonary bypass surgery, but the population that you did is just only for the cabbage.
Oh, yes, as in my...
Why don't you go back to the first, the renal outcome after the cardiopulmonary bypass in high-risk Cleveland Clinic score? So because the first time I read it, it's misleading to cardiopulmonary bypass can be valve surgery, can do pediatrics. Your population is not precise.
Yes, is in this score is can predict after cardiac surgery, all kind of cardiac surgery. Yeah. But this is my study is just catch up about the cabbage.
Yeah, why don't you put it in your heading?
Oh, my head outline like.
Your topic.
Oh yes.
Right. Okay. Do you have any questions?
Okay.
Did you calculate the sample size of the study?
Yes, it's included slide. Looks like the ไม่ได้เอามา in this slide not have the sample size, but
You didn't have it on your presentation?
yeah, I didn't put the sample size on this, but In my proposal previously, I had calculated the sample size, but actually is the sample size before I go to study is more than 20 in the broad group, but some the time and some the about the study is the start too slow and it's just 20, but my sample size is around 60 each size.
60 each arm?
Yes.
So this is still ongoing study, right?
That's my research.
Do this study?
I'm not sure. Might be that my professor is going.
Okay, we have lack of time. Move for the next section.
Thank you very much.
So the next paper is presented by Pativet, ใช่ไหม Effect of the hydroxytyl starch versus albumin as the cardiopulmonary bypass pump solution on platelet count, randomized control trial.
Thank you, Chairman and Co-Chairman. My name is David Sukothai. I come from Concat Hospital. Pumping solution are used to prepare the extracorporeal perfusion line in CPB application. Albumin has been commonly used as a component of pumping solution during surgical cardiac surgery for two reasons. Albumin can cause the fluid pathway that could result in decreasing protein nature, platelet activation and consumption, and release of inflammatory mediator. And albumin can attenuate the on-bypass following oncotic pressure that might lead to myocardial polyintestinal and cerebral edema. Another colloid solution such as hydroxyethyl starch also has been used as a component of pumping solution. Hydroxyethyl starch may also be less expensive alternative to albumin as a colloid solution. However, concern remain about the adverse effect of hydroxyethyl starch on the blood coagulation, especially when it's used in patient undergoing CPB. The recent study to compare the effect of hydroxyethyl starch versus albumin as a pumping solution during CPB in CVT patient is still controversy. So we conduct this study to compare the effect of hydroxyethyl starch versus albumin as a pumping solution in CVT patient. The aim of this study to compare the effect of hydroxyethyl starch versus albumin in pumping solution on decreasing in platelet count and positive kidney function and positive bleeding and blood transfusion. This is a double-blind randomized controlled trial. A patient with triple vessel disease who underwent CBG during August 2018 and March 2019. This study was conducted in Queen Sirkit Heart Center of the Northeast Faculty of Medicine, Concat University. The patient was conducted and divided randomly to the two groups. This study was approved by the Ethics Committee of Faculty of Medicine at Concat University, and all patients gave their informed consent before surgery. After calculate, this study have to have at least 20 patients in each group. This study includes the younger patient younger than 75 years old and patients who underwent elective or urgency CBG conventional, and patients with New York Heart Association less than 4 and have ejection fraction more than 35% and discontinue corticosteroid more than 5 days. The patient with the reduced surgery and competent other heart surgery, CKD, coagulopathy and pulmonary dysfunction, and chronic lung disease and severe liver impairment were exclusion. 46 patients were included in this study and divided randomly into the two groups. 6 patients were excluded from this study because received intraoperative IABP insertion and incomplete intraoperative data, and 1 patient underwent off-cap. Finally, the first group, 20 patients received a 6% hydroxyethyl and another group, 20 patients received 5% albumin as a priming solution. Statistic analysis was performed using STARSA version 14. The patient was randomized with box randomization. Categorical variable was expressed as a percentage, and normal distribution data was expressed as mean value and standard deviation, and compare between group using two simple t-test. And normal distribution data was expressed as the mean, and compare between group using mini-test. Statistic significance was set as a p-value less than 0.05. The result, baseline characteristic, there was no significant difference in baseline characteristic between two groups. P-relative data, P-relative data kidney level was higher in albumin group, and P-relative GFR was lower in albumin group significantly. Intraoperative data, platelet count was similarly decreased during on CBB time at the 15 minute second hour, and winning of the CBB in both groups, and no significant difference between two groups. There was no significant difference in intraoperative estimate blood loss between two groups. However, patient in hydroxyethyl group has been received intraoperative blood transfusion more than albumin group. And there was no difference in platelet decreasing of post-operative platelet count when compared with baseline between two groups. Positive data, there was no significant difference in positive but beating blood transfusion and using the dialytic between two groups. Overall post-operative GFR measuring from 8 hours to 72 hours were significantly higher in hydroxyethyl group. And there was no significant difference in time acceleration and length, ethyl length, hospital stay, and mortality rate in between two groups. Discussion. Our study that show hydroxyethyl solution with albumin when used as the component of priming solution similarly decreased, and no significant difference in intraoperative platelet count during on CBB at the 15 minute second hour, and during winning of CBB in both groups, and no significant difference in estimate intraoperative blood loss and post-operative blood loss. By the way, in hydroxyethyl group maybe tend to receive more blood transfusion than albumin group. And post-operative kidney function was better in hydroxyethyl group, maybe due to better pre-operative kidney function. And our overall study show similar result to the recent study, and confirm that hydroxyethyl can be used safely as a priming solution for CBB and CBT patients. Conclusion: 6% hydroxyethyl can be used as alternative colloid solution for priming solution during CPB. It isn't associated with adverse effect on intraoperative platelet count and post-operative kidney function compared with albumin. However, the patient tend to receive more intraoperative blood transfusion in hydroxyethyl group. In my study, have some limitation about the sample size as maybe a cause of unequal in portion for pre-operative creatinine and GFR. Thank you.
Any questions? Yeah, please.
What is your primary endpoint, and did your study answer your question?
My primary endpoint is about the study for the evaluate platelet count during on the CPB at the many time.
Did it answer your question?
Uh,
I mean, your primary endpoint is the platelet count, but
count.
your conclusion is another one. Just want to know.
I think my result is answer about the in the intraoperative platelet count for the compare the when compare the albumin is can alternative colloid used in cardiac surgery when on the CPB.
My question is why you interested in only intraoperative platelet count, like a day 1, day 0, I mean 8 hours, 1 day after the surgery. Why don't you interested in that? Because I think it's, I don't know, maybe a lot of manipulations during the CPB, right? Even we don't give the platelet, but we don't care about the platelet count during the CPB.
I think if during intraoperative procedure, if the maybe platelet count maybe drop more than normal, if it may be increased about the intraoperative bleeding. I think
There will any change if the platelet drop from difference, any change in strategy?
No.
No.
For the two colloid, not significant change.
And do you think from Dr. Nalongrit questions, is this, can you answer about the post-operative kidney function?
Yes.
Really?
For the my study, when use the albumin or hydroxyuretate, when after surgery, patient some patient have developed the AKI, but in the 3-day post-operative, third operative day, the patient recovery to the normal kidney function on of the baseline.
So from your result, the starch is better than albumin, right? For the kidney aspect?
Yes, it's the meditation of my study.
Your study, because that is not the primary questions. The population is not calculated based on your secondary question. You can only just for the primary questions. That one thing. And the second thing, if you think that albumin is worse than starch, you have a long argument with the nephrologist. This will change the practice. You will not comfortably walk through the medicine. Okay, thank you for your study. So I think we have to move on, right? We have a lot of interesting presentations. So next one is we have a lot of randomized control trial. Randomized control trial study of sacubitril valsartan versus enalapril for ejection fraction improvement in low ejection fraction patient underwent cabbage surgery from Dr. Waraj.
I'm from Pharmacology Hospital.
Okay.
Thank you, Mr. Chairman. Good morning, everybody. Our study is a background from the Paradigm trial, show that sacubitril valsartan was superior to enalapril in patients with heart failure and low ejection fraction. This implies that true drug has an effect on improvement of ejection fraction, more or less. In our cardiothoracic surgical service, there is a certain number of patients with coronary artery disease and low ejection fraction who are indicated for coronary artery bypass graft surgery. In such patients, there is no study conduct compare the benefit of ejection fraction improvement from this two drugs on top of coronary artery bypass graft. The objective is to study the outcome of ejection fraction improvement in patients with coronary artery disease and low ejection fraction who underwent only coronary artery bypass graft and receiving sacubitril valsartan compared with Intraoperative in short-term follow-up. Material and method. Our study is a randomized controlled trial study was done at Pramongkutgao Hospital from June 2018 to February 2019 in patients with coronary artery disease and low ejection fraction who underwent only coronary artery bypass graft in elective surgery. Total case is 44 case. Pre-operative confirmation of low ejection fraction by echocardiography, and then double bind into two groups, equal to 22 cases per group. Experimental group receive sacubitril valsartan on top of coronary artery bypass graft, and control group receiving Intraoperative on top of coronary artery bypass graft. In experimental group, the patient died 2 cases. In complete data, 5 cases. The overall case is 15 cases. In control group, have a death 4 cases. In complete data, 4 cases. Overall case is 14 cases. And then standard follow-up regimen with echocardiography at 3 months after surgery. And then result and conclusion. Because my research did not study before, my sample size is calculated from baseline on Journal of Improvement of Ejection Fraction after only coronary artery bypass graft in patients with low ejection fraction in Bosnia and Herzegovina. And from statistic formula of inferior non-inferior trial of Shunt and low. The statistic significant sample size in each group is equal to 13 in each group. The result. In a baseline characteristic about age, BMI, underlying disease, diabetic mellitus, hypertension, CKD, and smoking, alcohol is no significant in both groups. But in preoperative lab investigation, Intraoperative group have a better than sacubitril valsartan group in creatinine and ejection fraction. In surgical situation, there is no significant difference between 2 groups in syntax score, Euro score, and New York Heart classification, cardiopulmonary bypass time, cost cap time, and number of distal anastomosis. When compare post and pre-operative lab investigation, in creatinine, GFR, and hematocrit, no significant change. But in ejection fraction is a significant improvement in both groups. But the amount of improvement was more by sacubitril valsartan group than in Intraoperative group significantly. In result of complication, in Intraoperative group have 5 patients that rehospitalization in 3 months post-operatively with heart failure, but in sacubitril valsartan group has only 1 patient. And in sacubitril valsartan group has more significant difference reduced post-operative diuretic duct. Discussion. There is significant improvement of ejection fraction in patients with left ventricular dysfunction who underwent coronary artery bypass graft surgery and receiving both sacubitril valsartan and Intraoperative group. But the amount of improvement was more by sacubitril valsartan than Intraoperative. And rehospitalization from heart failure condition in Intraoperative group has significant difference than circulative valsartan group. Our conclusion: in patients with coronary artery disease with low ejection fraction who underwent coronary artery bypass graft, the short-term follow-up showed that cardiac ejection fraction can be significantly improved post-operatively by both intraoperative and circulative valsartan group on top of coronary artery bypass graft. But the amount of improvement was more by circulative valsartan than intraoperative group. Therefore, circulative valsartan can be a better alternative in coronary artery bypass graft patients with low ejection fraction. Additional notice: my research have a little noted that discontinuation of diuretic drug at 3 months can be done more on circulative valsartan group with significant compared with intraoperative group. And the hospitalization from heart failure condition in intraoperative group have more than circulative valsartan group significantly. The limitation of this study is a short-term follow-up. And further, if possible, we could long-term follow-up and multi-center study. Thank you.
Has any questions from the floor? Yes, Dr. T.
Look in the baseline characteristic. Your study compared improvement of LV ejection fraction, right? The baseline. Your study compare improvement of the LVEF between the two groups, but the baseline characteristic, the baseline LVEF is not the same. You can see. Yes, I wonder how you random the patient to have this kind of different.
About preoperative baseline.
Yes, EF is so different, too different.
This slide pre-op, but my research, our research is a randomized control trial and preoperative double-blind patient into two groups. The ejection fraction is in intraoperative group have better than circulative valsartan group because double-blind patient into two groups.
You mean that this is occur by chance?
Yeah.
But this is preventable because the LVEF pre-op is very important to your result. So you have to conduct the randomization in the way that balance these two, such as you have to stratify your randomization according to the LVEF level, less than 10, less than 20, and something like that. And you can better distribute this factor. And about the sample size calculation, I think the reference paper cannot be used in this context because that is not about the drug, but about the cabbage, right? And you cannot bring that number into your calculation because additional to the cabbage effect of these two drugs more or less have to be smaller than the effect of cabbage alone. So the actual number of study patients have to be a lot more than this because the effect will be smaller than the cabbage itself. So I don't think you can bring this paper to be a reference. Thank you.
Yes.
Okay. I'm sorry about because I don't know. Can we conclude the result of the improvement of the EF from the medication? Because as we all know that the lower the EF post CBG, usually the patient will improve the LVEF somehow, but the lower, the better. So in your pre-operation, your circulative valsartan is lower, so it can be the better. Just by CABG.
Yes.
You understand.
I understand that. Yes, only CABG can improve low ejection fraction in this patient group. But my research is an alternative way that combine the standard regimen and alternative drug. Is the alternative way to treat patient.
And all of the patient has only one hepatitis drug?
In each group, in my research and our hospital, have received one beta blocker, such as bisoprolol, and the additional is enalapril group and sacubitril/valsartan group. Yeah.
Thank you very much.
So thank you for, before we late, so we come to the next sessions. The next is from Dr. Kalanrat. Oh, sorry. Yes, it's from Dr. Shayut from the Chulalongkorn Hospital. So the topic is about the outcome of the coronary bypass surgery of multiple arterial graft versus single arterial graft in multi-vessel disease. Please start.
Good morning, Professor and everyone. My name is Shayut Siwathanawarashai from King Chulalongkorn Memorial Hospital. What is the optimum secondary conduit for CABG? Artery or veins? This question is so simple but important and hard to answer. I have nothing to disclose. In 1986, the Cleveland Clinic published the landmark paper describing the benefit of the single left internal mammillary artery, LIMA. This conduit provided superior long-term survival compared with the sphenoid vein. That changed the clinical practice. LIMA to the LED became the standard of care. Eventually, the arthritis by David Taggart had identified a survival advantage for the bilateral IMA at 10 years in the Statistic Analysis. Mario Gallino performed the meta-analysis that showed radial graph that in superior angiographic patency compared to the sphenoid vein at 5 years. However, the current use of bilateral IMA and radial artery in clinical practice remains about 5% in the United States. Oh, sorry. Multiple arterial graft in CABG remain controversial. How many multiple arterial graft in CABG have we performed in our center? The aim of this study is to compare the clinical outcome after CABG of multiple arterial graft versus single arterial graft. As a leader and provider for tertiary service, King Chulalongkorn Memorial Hospital offers many patients every year from all regions. We review all patients who were admitted between January 2012 and December 2013. The extra extract from the operative registry, admission record, outpatient and emergency department visit for the long-term follow-up. Propensity matching used to minimize the selection bias, and Kaplan-Meier used to estimate the survival. Therefore, we include all patients who have primary isolated CABG. All patients in the study must be more than 18 years old at time of surgery. However, we exclude in case of LIMA not used, single distal anastomosis, and missing data on graft strategy. The primary endpoint is all-cause mortality. The secondary endpoint consists of stroke, myocardial infarction, re-intervention, and a composite of death, stroke, myocardial infarction, and re-intervention. So let's to the result. The study population, 303 patients was performed CABG between 2012 and 2013. 66 patients was excluded because not received the LIMA. We live with 233 patients. 83% is single arterial graft and 17% is multiple arterial graft. We propensity match 41 pairs. This table presents the baseline characteristics. On the left, the primary cohort. On the right, after propensity match. As the table suggests, both groups are differ significantly in many aspects. We decided to perform propensity match analysis and found that these factors are no longer significantly different. First, we focus on the primary cohort. In single arterial group, the patient was older and have a higher BMI than multiple arterial group. In multiple arterial group, almost patients are male. Coronary artery disease severity is similar in two groups. Next, comorbidity characteristic. None of the patients in the multiple arterial group have a dialysis, peripheral arterial disease, and cerebrovascular disease. Aftermath not show the difference. No difference in the prevalence of diabetic hypertension, dyslipidemia, and atrial fibrillation. The other comorbidity, no difference in the prevalence of COPD, pulmonary hypertension, active smoking, preoperative intra-aortic balloon pump, and post-cardiac arrest. Myocardial infarction rate is similar in two groups. Previous PCI have higher prevalence in the single arterial group, but no significantly different. The preoperative hemoglobin and creatinine are significantly different in a single arterial group. And left ventricular ejection fraction, plasma glucose, LDL level, albumin are similar. In hospital, mortality was only 2.1% in single arterial group, and none of the patients in multiple arterial group were dead. Operative characteristic. We perform elective surgery higher in the single arterial group. Almost patients will perform conventional CABG. The number of distal anastomosis per patient was 3.3. We use only radiograph as a secondary conduit. The operative time. Multiple organ take more operative time, CPB time, and cross-cam time in both primary cohort and propensity match. Okay, the primary endpoint. Median follow-up time is 5 years. On the left, the primary cohort, on the right, propensity match. As demonstrated in the Kaplan-Meier curve, 5-year mortality was not different from multiple arterial group compared with a single arterial group. The secondary endpoint, stroke rate, was not different at 5 years. Myocardial infarction rate was not different at 5 years. Reintervention was different at 5 years in a multiple arterial graft of primary cohort, but the event was only one, and aftermath no longer significant. Also, the composite outcome was not different at 5 years. In summary, multiple arterial conduit is underutilized in the clinical practice. Compared to single arterial graft, multiple arterial graft was similar in the mortality at 5 years. The limitation of our study. No data on compliance with secondary prevention. Angiographic data and intraoperative targets was not available. We were unable to identify the crossover from multiple arterial graft to the single arterial graft group. Selection bias from the retrospective study. I know that my study is lack of data pool due to the only single center. Larger study is longer follow-up and larger study and longer follow-up for necessary. I hope that in the near future, every center in every part of Thailand will cooperate for promising future together. Thank you for your attention. If you have any questions, I will be delighted to answer them.
Yes, any questions from the floor? So I have a few suggestions, because I think you compare between the vein graft and the arterial graft. The vein, we know that patency, we talk about 10 years, but your study is collect the time is about 5 years, maybe like your suggestion we saw. If we collect more years and more patients, maybe we see the difference between both groups.
Thank you for your
Okay. So because of the time, we go to the next sessions. The next is the comparative study of efficacy and safety of bilateral vs unilateral radial artery ASCVTS bypass conduit. The presents from Sri Lanka Hospital by Dr. Karalat Unasuson. Please start.
Good morning, Chairman and everybody. As you may know, 2018 ESC guidelines on myocardial revascularization mentioned that the radial arteries for non-LED targets have been shown to provide better patency risk than the saphenous graft and has been linked to improved survival. Moreover, radial artery has been used extensively as a way of completing of arterial graft for revascularization. In some patients who had the problem with lower limb, the use of radiatory is the way to reduce the use of saphenous grafts. So we wonder, if we had a way to encourage using radiatory conduit, it should be a better way for the patient. However, the use of radiatory conduit limited in non-dominant forearm because the surgeon afraid of the complication in donor forearm, such as the risk of hand ischemia, infection, and neurological dysfunction after harvested. So we want to demonstrate the effectiveness and safety of harvesting bilateral radial arteries. We also compare post-radiatory harvest hand perception between patients having bilateral radial arteries harvested and patients having unilateral radial artery harvested. This is a retrospective cohort study. The patients undergoing CABG using radiatory at Siriraj Hospital from January 2007 to December 2018 were screening. The patients performed under single surgeon were included. This is the flow chart of patient selection. We included the patient used radial artery undergoing by single surgeon. Then allocated the patient into two groups. First, the patient who were used bilateral radial arteries, and another group for the patient who were used unilateral radial artery, with random selection by 2:1. We excluded the patient that lost follow-up and death in both groups, and exclude the patients who was used dominant hand in unilateral group. Finally, there were 64 patients in bilateral radial artery groups and 109 patients in unilateral groups that were analyzed. When the patient came for follow-up at the time more than 12 months after operation, they will ask to complete questionnaires about harvest hand perception. The questions are related to the perception of complications such as pain, numbness, swollen, scar, and others. The minimum sum score is 8, and lower score determine better outcome. This table shows characteristics of patients included in the study, which show no significance in any data, except that in patients with triple vessel disease in unilateral groups is significantly more than bilateral group. For the post-harvest hand-related complications, it demonstrates the patient who developed immediate post-operative hand complications in bilateral groups were 18 patients, which was more than unilateral groups that were 9 patients significantly. But at the time of follow-up, there was no significant difference between two groups, and there was no any hand ischemia found in our study. Subgroup analysis of post-harvest hand complications in bilateral radial artery groups demonstrated 15 patients developed complications in non-dominant hand, which were more than 9 patients who developed complications in dominant hand significantly at the immediate post-operative period, and also the same reasons after follow-up. The hand perception score delivered from the questionnaire, when compared only in non-dominant hand between two groups, the patient in bilateral group had more hand perception score, which mean is 8.7 versus 8.3 in unilateral group significantly. Subgroup analysis in bilateral group was performed and showed no significant difference in hand perception score between dominant and non-dominant hand. For non-hand-related outcomes, the patient in bilateral group had been performed more number of arterial coronary anastomosis, which was 4 when compared with 2 anastomosis in unilateral group. However, the median operative time was 160 minutes and cardiopulmonary bypass time was 80 minutes in the bilateral groups, which were also significantly longer than unilateral group. So the variable that related to the operative time were analyzed. After backward multiple linear regression model was performed, It showed the variable that true significantly related in operative time were only number of arterial distal coronary anastomosis and cardiopulmonary bypass time. So we make a discussion. Despite higher immediate postoperative hair-related complications in bilateral groups, after follow-up, there was no significant difference between two groups. It revealed that hair-related complications occur in immediate postoperative period can be improved after the time pass and make no difference between two groups after follow-up. Hair-related complications in non-dominant hand were significantly higher than in dominant hand, may be related to the experience of the surgeon that participate in the operation, because we usually assign the experienced surgeon to harvest from dominant hand. It would be the same reason when compared only in non-dominant hand perception score between two groups. The patient in bilateral group had more hand perception score because the more radial artery we use, the more surgeon we need, and the more younger surgeon attend to the operation. After linear regression model was performed, it showed the variable that significantly related in operative time were arterial coronary distal anastomosis and cardiopulmonary bypass time, but not directly related to the number of radial artery used. It showed the bilateral radial artery use was not resulted in prolonged operative time. But we can get more arterial coronary anastomosis in bilateral radial artery groups. However, there are some limitations in our study due to retrospective nature, and different time points at the questionnaire administration may affect hand perception score. So we conclude that the bilateral radial artery conduits can be used effectively without the persistent difference in hand-related complications. The hand-related complications were minor and improved over time, and radial artery from dominant forearm can safely be used. Thank you for your attention.
Any questions? Yes, please.
Are you monitor motor function of the hand?
Yes, we not directly motor function, but we include in the questionnaire that we ask the patient to complete when they follow up about not that maybe the surrogate outcome of the hand function. And there was no report about the complication about motor function when the patient came for follow-up.
Any problem for the complaint of the patient about the numbness or hand function is which change compared to before operation? What this study? Any record?
Before the operation, there was no record.
Okay.
So you said, I think I saw that one of your methodologies that it said is randomization, right?
No, I just random the patient in the groups of unilateral radial artery to be the to let the number to be the 2 to 1.
Why don't you use propensity match? And the second, go to the result or discussion. Of course, because you said the more complicated. Go move ahead. Mm-hmm. A little bit more. More. Yeah, I think it's a not conclusion, discussion. Yes, higher immediate post-operative hand-related. Another page, another one. Yeah, hand-related complication in dominant hand is significantly higher than can you explain it?
In non-dominant hand, because when this is a result from subgroup analysis in the patient that use bilateral radial arteries, and When we perform the operation in the bilateral group, we usually assign the experienced surgeon to harvest from dominant hand. So maybe it leads to the complication more than in non-dominant hand because the less experienced surgeon perform in the non-dominant hand.
This is only bilateral patient, right?
Yes.
Only bilateral patients. Okay.
The reason why we didn't did propensity score matching analysis because most of the patients with a single radial artery follow up elsewhere. So we have more or less a limited number of patients to include in the analysis and to complete the questionnaire. So we try to enroll more.
Yes, I think because patient has one incision compared to two incisions. It's straightforward to result that have more complication or more numbness, right? Okay. Any questions? So moving on to the next topic, the outcome of coronary bypass grafting in oldest old patients. 5 years retrospective study. What does it mean, oldest old? So you have just one patient?
No.
Oldest old.
Good morning, Mr. Chairman, Co-Chairman, and everyone. Thank you for opportunity to presentation. My name is Krisapong Sirisan Sakda, Fellowship in Cardiovascular Thoracics in Pharmacology Hospital. Today, I would like to present my study. Outcome of coronary bypass grafting in elders old, a 5-year retrospective study in Pharmacology Hospital. My advisor is Dr. Sakat Laksasap. The world's population is coming aging. Oldest, the United States define term of oldest old as people who age 80 or more. In next 30 years, number of Thailand oldest age people coming top 20 of the world ranking. Due to decreased functional capacity of the organs and morbidity in general, post-operative complications are common in aging patients than young patients. High complications may result in high mortality. As same as other major surgical procedures, heart surgery in this patient group still debate. It would be good if we can predict and select the patient who will be good result or good outcome in post-surgery. Then my objective are determine preoperative factor that they associate the post-operative mortality. Study design, we 788 patients who underwent coronary bypass grafting in Pharmacology Hospital between January 2014 to December 2018 for my hospital database. We collect and analyze the clinical characteristics as a show: age, sex, comorbidity, functional class, syntax score, Euro score 2, detail of operation, outcome, 30-day mortality rate, complication, readmission rate, and length of stay. 201 were age 80 or older. After acute redo case, wrong diagnosis, and missing data, totally 101 subjects in this study. Statistic Analysis, I use the IBM SPSS program version 24. The statistical we report category data by percentage. Continuous variable were reported by mean and standard deviation. Using chi-square feature exact test to define association between the two variables. Significant p-value I set below 0.05. I using multivariate logistic regression to calculate the adjust odds ratio and determine relationship to mortality. Let's see the result. The demographic data show that the mean age was 81 years old. Common comorbidity consists of hypertension, dyslipidemia, diabetes, and chronic kidney disease, respectively. 24% of patients have been diagnosed of acute decompensated heart failure. The mean LVEF was approximately 50%. Severe dysfunction category was 14%. Nearly 50% underwent off-pump CABG. 6% were used Lima graft with gasophilate vein graft. All-cause mortality rate in 30 days was 9.9%. About 15% need medical circulatory support. Nearly 6% need to lysotomy due to bleeding or tamponade. After we put the, surprisingly, 92 patients of 48% will develop post-operative acute kidney injury. Approximately 1/5 of those patients need to initiate hemodialysis. All pre-op and operative factors were analyzed in univariate and multivariate logistic regression, shown as the slide. When off-pump, using of Lima graft, New York classification class 4, on-pump CABG with other operation, emergency timing, and acute decompensated heart failure, history of acute coronary syndrome, and Euroscore more than 5% are significant in univariate. And then I put to the multivariate analysis, show only on-pump CABG with other complications and acute decompensated heart failure are significant. There are odds ratio, adjust odds ratio is 5 and 6 for p-value below 5.05. In discussion, there are studies in the other country about study in the patient who age 80 to 89 years old. There are mortality rates 7.1%. Compare our study. My study have more than mortality rate because maybe the subject in my study high prevalence of decompensated heart failure, 24%. Conclusion. Coronary bypass grafting could be feasible in oldest or patient with good medical condition, and this study demonstrated a high complication high post-op complication such as acute kidney injury, bleeding, or pneumonia. I conclude that we should the operations can be feasible, but we should prompt to collect the post-op complication, maybe reduce mortality rate. Thank you.
Have any question on the floor? Yes.
What is your research question?
Thank you for your question. My research question is the oldest old patient group maybe have a high mortality in the post-surgical operation. Then it would be good if we find the risk factor to our group of this patient to beware the outcome, bad outcome.
And what is the answer? And how you incorporate your research in your practice?
In my practice, I think I use this data to maybe in some case can be postponed the operation to from emergency case that the patient who are still acute heart failure to the urgency case after do the operation after the heart failure is improved, maybe improve the positive outcome.
You show that the emergency CABG is around 50% dead. Is it?
เปิดสไลด์หน่อยครับผม
Emergency case is only 9 case, 4.7%. Do in
dead rate.
Dead rate.
How many cases dead for emergency?
6 case in 19.
It is okay. How about if you compare to the another paper? Is it similar or not?
My study is higher rate to compare when compared to another study.
What the reason?
Maybe the time maybe my population is high rate of the acute decompensated heart failure, and there too is high comorbidity than other study.
Why didn't you compare your population with maybe younger old group, let's say 70, 80?
This study calculates the sample size based on prevalence of mortality of the patient who aged more than 80 years old. The sample size not calculated on the overall of the post-op mortality after surgery. Then I think I should not compare with the other population.
Okay, congratulations for the papers. So we move on to the next papers. The next paper presented from Nasha Bunjwatchanapans from the Konkan Hospital about the incidence, risk factor, and outcome of prosthetic valve endocarditis after valvular replacement for native valve endocarditis. Please begin.
So thank you for a very nice introduction. Good morning, Mr. Chairman, ladies and gentlemen. So this is my headings today. Introductions. All around the world, we have the patients who underwent the valvular replacement, and some of them faced with the prosthetic valve endocarditis, which is associated with significant morbidity and high mortality. The recurrence infection was higher in the native infective endocarditis group. From the review, we found that 1 to 6% of the patients underwent valvular surgery exposed the PVE or the prosthetic valve endocarditis. And furthermore, in the specific group, which is the IE groups, there was around 16 to 34% incidence, and the mortality was increasingly high and wide, around 20 to 80%. The risk factors is about in the hospital mortalities, it was about the female patients, shock, previous surgical procedure, multiple valvular involvement, abscess, or the urgent surgery. So my purpose of the study would be, firstly, the incidence of the prosthetic valve endocarditis, secondly, the risk factors, and lastly, the outcomes of the prosthetic valve endocarditis in IE patients who underwent surgery. So my paper was a retrospective study. We include all of the patients who were the native infective endocarditis patient with the valvular replacement in Khon Kaen University. We enrolled for 2 hospitals in Queen Sirikit Heart Center and the Sinakarin Hospital from January 2005 to December 2015. We explore about the demographic data, the pre-operation, intraoperation, also the post-operative results were analyzed. And about the risk factors, we used the univariate analysis logistic regression for access those of the risk factors. Statistic was a standard 10.1, and for the quantitative variable, we used mean and range. And as mentioned before, we use the univariation logistic for risk factors. So this is the results. The incidence of the PVE was around 8.75%, and more than a half of the patients come early within 1 year. The duration of antibiotic was around 4 to 6 weeks before second operation, and the mean age was around 41 years. This is the demographic data. Mostly of my patients were male, and they had a really good ejection fraction at the first start, around more than 50%. The comorbidity was a stroke predominantly, and the associated lesion intraoperative was around 18, which is the rheumatic heart disease. So the isolated valve, which is very involvement, is the aortic valve, and the valvular replacement, which is mechanical or tissue quite equally, and the hemoculture. The number one was a Streptococcus species, around 11%. So from all of the patients, around 80 patients, I tried to find the risk factors between the PVE and the non-PVE group. So you can see that the univariate analysis didn't show any significance of the study. So I come into the PVE group. So this is a very small number. There was only 7 people. Mostly they were male. And the aortic valve isolated was predominant again. And the mechanical was around 42%. The presentation of the patient comes with the congestive heart failure, more than 50%. Surprisingly, the hemoculture was no growth, more than 80%. And the timing of reoperation was urgent. And the indication for reoperation was severe prostatic dysfunction due to the prostatic valve dehiscence. So the outcomes, the in-hospital mortality in the group was around 28%, and the overall survival was around 42%. So discussion about from the review to my study, the incidence was around 8.75, which is a little bit lower, but the in-hospital mortality was around 28, and the majority of the mortality was a cardiogenic shock and cardiac arrest. However, the risk factor, I couldn't find any significant. So my results were associated with the previous study in terms of mortality, but the lower incidence and non-significant risk factors was not compared to the previous study. Conclusion. So firstly, my incidence was around 8.75%. The in-hospital mortality was 28, and overall survival was 42%. And in my study, there was no statistical significance for the risk factors. Of course, my limitations, firstly, it was a retrospective nature study, so a lot of bias and about the data collection errors. Second one, it was the single center study. And lastly, it's very small volume study cases. Thank you for your attention.
Congratulations for your study. Did anyone have a question? Yes, Dr. T.
How did you calculate the incidence?
The incidence, you mean the incidence and then the percent of the population?
8% somewhat. How did you calculate that?
You mean for the You mean the population, right? Because
I don't know your number. Calculate from what incident, which number divided by which number in which time frame.
From at the beginning, I used the percent of the incidence around 22, which is the median numbers, and the errors I use 5.
I mean your result. The result, the 8% come from what number?
8% come from the whole of the group, because my population was 80 people, and the incident was 7, so it's around 8.
Oh, you cannot say that number is incident. That is not incident. Just a percentage of the PVE out of the whole IE patient who underwent operation, right?
Yes.
If you were to calculate the incident, you have to beginning the clock as the first operation, and then you follow all patients who have prosthesis, and then you end up with how many cases out of the whole prosthesis got infection.
Because the 80 was the first people who has IE with the operation, and then after they got infection,
you cannot call that incident. You have to call that just percentage, not incident.
Thank you.
And question is, how do you define the endocarditis at the first population? Is it culture positive or the tissue positive or whatsoever? Okay. And how about let's say, because the recurrence rate can be affected by the tissue culture is positive or not, right?
Because from my paper, I enrolled the patients by coding the paper. So I try to find the IE patients plus the underwent surgery. So if I got the paper, I try to criticize that they were IE actually or not.
Maybe possible that someone had a healed IE, right?
Yes. So even sometimes if you have the paper with the IE patient, but when I criticize, it was not the true one. I just let it go.
Yes, due
Thank
to
you
the
so
time.
much.
So the next paper is from Dr. Sukit. The study is to do 2 different mitral valve approach impact the clinical adverse outcome, a single center observational cohort study. So let's start.
Okay, good morning everyone. Today my topic is do 2 different mitral valve approaches impact clinical adverse outcomes, a single center observational cohort study. To begin, mitral valve repair is the standard treatment for mitral valve disease when the repair is expected to be durable. We usually approach the mitral valve via left atrium, posterior to the sonograph group. But because good exposure is another key of success for good mitral valve repair, Dr. Giradon proposed superior transeptal incision as another alternative approach. As you can see, vertical line atriotomy was made. Then we extended the incision superiorly to the roof of left atrium and extended inferiorly to the posterior margin of fossa ovalis. However, there are still some concerns about complications such as risk of bleeding and bradyarrhythmia. So, in this paper, we performed prospective cohort observational non-randomized study performed in single center. The patients was divided into 2 groups. Group A, superior transeptal group, and Group B, classical left atriotomy group. Our inclusion criteria include all patients who underwent mitral valve surgery with or without concomitant procedures from December 2018 to August 2019. The exclusion criteria are patients with preoperative 6 syndrome, heart block, temporary pacemaker or permanent pacemaker used, abnormal thyroid function test, or concomitant MACE procedure, or aortic valve replacement. The primary outcome is permanent pacemaker implantations, and secondary outcomes are temporary pacemaker use, resolution of bradyarrhythmia at follow-up, post-operative breathing and blood product use, or breathing reoperation, and maintenance of sinus rhythm in patients with preoperative sinus rhythm. On the first day, we monitor the EKG continuously, and the next 3 days, we record EKG every 8 hours by nurse. Then we follow up the patient at 2 weeks and perform 12-lead EKG. If the patient has symptomatic bradyarrhythmia, we put the patients on temporary pacemaker. And if the patients need temporary pacemaker more than 7 days, then we consult the cardiologist for permanent pacemaker implantation. If the patient's intrinsic rhythm is faster than pacing rhythm, or in the morning round, we turn off the pacemaker to see the patient's heart rate. If it's more than 50, we decide to turn off the temporary pacemaker. Our statistical analysis include percentage for categorical data, and for continuous data, we use mean and standard deviation for normal distribution, and median and interquartile range for non-normal distribution. Then we compare with independent t-test, Mann-Whitney U-test, or chi-square test. If the p-value is less than 0.05, we consider it significant. So for the result, 271 patients admitted for mitral valve surgery. 172 patients were excluded, mostly because of concomitant aortic valve replacement. 99 patients met the inclusion and exclusion criteria. In Group A, there are 51 patients, and Group B comprised 48 patients. So for the baseline characteristic, the age, gender, height, body weight, underlying disease are the same between two groups, except that Group A has more chronic kidney disease than Group B, and Group B has more prior cardiac procedures than Group A. Preoperative EKG, functional class, and medications are also the same between two groups, but Group B has more digital risk use than Group A. Preoperative echo data are also the same. For mitral valve disease, most patients in both groups have severe mitral valve disease. Group A has more mitral regurgitation, while Group B has more mitral stenosis. For mitral etiology, Group A has more degenerative disease and IE, while Group B has more rheumatic disease. Most patients in both groups have severe functional TR, but Group A had more severe disease. Mitral valve repair and concomitant tricuspid valve repair were performed more in Group A. Group A also has more cross-clamp time than Group B, while cardiopulmonary bypass time and estimate blood loss were the same between two groups. There are no permanent pacemaker implantations in both groups. For temporary pacemaker, 4% of patients in each group need to use temporary pacemaker. When we look at this patient, both the timing and length of temporary pacemaker use are the same between two groups. After the operation, we can see that 10% of patients in each group have junctional rhythm. And this 10%, 80% of these patients that got junctional rhythm start to have junctional rhythm at post-operative day 1. Then we follow up the patient at 2 weeks after discharge. We can see that there are no junctional rhythm observed. Then we analyze the patient with preoperative sinus rhythm. We can see that most patients in both groups regain sinus rhythm at follow-up visit. There are no difference in 24-hour drain volume, pack ratio used, breathing reoperation, mortality, ICU stay, and hospital stay between two groups. So, in conclusion, this study showed that superior transseptal approach did not increase adverse outcomes, including breathing, post-operative arrhythmia, and rate of pacemaker implantation when compared to the classical left atrial approach. So, superior transseptal approach can be a safe alternative approach when performing mitral valve surgery to increase exposure. Our limitations include limited sample size, nature of non-randomized observational study. So further study with larger sample size and randomized experimental design should be performed. So this concludes my presentation. Thank you for your attention.
Thank you. Have any questions? So I have a few questions because they have some difference by indication. Like if we have some large LA, we will perform the transeptal, and if we have small LA, sometimes we will perform the classical LA approach. Did you have some management of this confounded by indications?
No, because this study is observational study, and the selection of patients into each group based mainly on the surgeon judgment.
Yes. And it's my suggestion, because your number is okay, but I think when you compare between two groups by the cohort and retrospective like this, maybe proper for like propensity score matching is maybe make the two groups more the same and better compare for the result. Okay, for the times for the next sessions, we have the paper about the outcome of the correlates of left subclavian artery during endovascular repair for the thoracic aorta in last week hospital experience by Dr. Yovasit. Okay, he not come, so we go to the next by Dr. Padet, and the topic is about neurological outcome in thoracic endovascular repair with the left. Oh, sorry. Oh, okay. It's quite the same topic, yeah. Neurological outcome in the thoracic endovascular aortic repair with left subclavian correlate. So let's start.
Okay, thank you for the introduction. Good morning, Professor and colleague. I'm Padet Thangtiapong from King Chulalongkorn Memorial Hospital. And here's my study, the neurological outcome in thoracic endovascular aortic repair with left subclavian artery coverage. Up to 40% of patients underwent TEVA in need of left subclavian artery coverage to achieve adequate proximal landing zone, which include that TEVA zone 0, zone 1, and zone 2. Coverage of left subclavian artery increased the risk of poor neurological outcome, especially posterior circulation system, which was supplied by vertebral artery, and spinal cord, which was supplied by anterior spinal artery. However, the poor neurological outcome in TEVA are multifactorial. So here is my research question. Does the left subclavian revascularization reduce the risk of neurological complication of patients undergoing TEVA with left subclavian artery coverage? The primary outcome of my study is the poor neurological outcomes, including anterior circulation stroke, posterior circulation stroke, spinal cord ischemia, and left subclavian steal syndrome. For the secondary outcome is in-hospital mortality. For the method of my study, the research design, we did the retrospective study, which included that the patient underwent TEVA with required coverage of left subclavian artery in cardiothoracic surgery department of King Chulalongkorn Memorial Hospital from January 2006 to June 2019 is about 14 years. The inclusion criteria are the patients aged over 18 years old who underwent TEVA with left subclavian artery coverage, and we included those with incomplete pre- and perioperative data. From 155 patients underwent TEVA with left subclavian artery coverage, 3 patients that had incomplete data were included. So the total number of our population was 152, which consists of 68 in left subclavian artery revascularization group and 84 without left subclavian artery revascularization group. Here's my result. Baseline characteristic of our population mostly are elderly male with a mean age of 70, and both groups are not significantly different. For the underlying disease, we included those related with metabolic syndrome and factor related to stroke. The prior stroke incidence were higher in group without left subclavian artery bypass. However, it's not statistically significant. For the aortic pathology that require TIVA, fusiform aneurysm often done in 84 patients, which is 55% of overall patients. Acute aortic syndrome came in second, and secular aneurysm came in third, with a small number of chronic aortic dissection, branch traumatic aortic injury, and otitis. From this table, we can see that both groups are not different in terms of aortic pathology. We did TIVA in elective operation for 120 patients and 32 with emergency operation. In elective surgery, we did less left subclavian artery revascularization. Opposingly, in emergency setting, we did revascularization more. For the landing zone, mostly we did TIVA in zone 1 for 41%, zone 2 for 33%, and zone 0 for 26%. And we subgroup zone 0 into 5 groups according to the revascularization to the brain, which mostly is chimney stent. We demonstrated that both groups are not different by the mean of the landing zone. And we studied the vertebral artery dominance and the diameter of vertebral artery from the preoperative CTA, and we found that most of our population has a co-dominant vertebral artery, about 50%. And the diameter of the right vertebral artery was significantly larger in group without left subclavian artery bypass. Focusing on the revascularization technique, only one with aortic subclavian bypass and one with chimney stent. Other were carotid left subclavian bypass. For the left subclavian artery, mostly we didn't occlude the origin of left subclavian artery. And for those that we occlude, we use the Amplacer device for the most of the patient. And all of the devices are proximal to the left vertebral artery from the CT postoperative. We had 6 patients that had delayed left subclavian artery revascularization, 3 due to the left subclavian steal syndrome, and 1 due to the left vertebral artery dominance after the review CT postoperative, and 2 due to post-circulation stroke, 7 patients. Talking about the primary outcome of our study, we found that we had more poor neurological outcome in the group with left subclavian artery revascularization as compared to the group without. However, there is no statistical difference in total and each of them. Looking in the detail, the numbers were not quite different. What is more apparent in the spinal cord ischemia and left vertebral steal syndrome. For the spinal cord ischemia, we found 3 cases which were all in the left subclavian artery bypass group, which quite surprised to us, but we will discuss about this in the next slide. And we found that left subclavian artery steal syndrome in 4 patients in group without left subclavian artery revascularization, which was expecting. Or the patient that had postoperative spinal cord ischemia has a long segment of endovascular repair, as you can see in this table. And for the secondary outcome of my study is in-hospital mortality in both groups are not statistically significant different. We did univariate and multivariate analysis. Only the dyslipidemia was found to be the risk factor of poor neurological outcome with the odds ratio of 3.33 and p-value of 0.01. And after we analyzed for multivariate model, odds ratio was 3.81 with the p-value of 0.01. The left subclavian revascularization, emergency surgery, and landing zone did not reach statistically significant in univariate. And also the vertebral artery dominance and diameter. For the discussion of my study, in 2014, there was an attempt to try to answer the question with this multi-center retrospective study, which included the patient of 1,002. The study showed that stroke rate was lower in the patient that underwent pre-op revascularization. However, this is quite different to our study for the result. But in the meta-analysis in 2016, which included 5 observational studies of 1,161 patients, in this study, they cannot show statistical significance in stroke and spinal cord ischemia between both groups, with quite similar to the study. So the role of left subclavian artery revascularization is still a controversial issue. The limitation of my study is it's retrospective in design and the low event rate of stroke. To summarize my talk, we cannot show the statistical significant difference in poor neurological outcome in 2 groups. Further study might be needed to answer the question. Thank you.
Have any questions from the floor? So I have a little questions. because from my experience and the result of Chiang Mai University, I think the stroke is more than upon from the bypass of the vessel. Is the atherosclerosis part from the aortic vessel. Did you collect the data about the atherosclerosis or the plaque or the severity of the aorta like this? That is I think it's maybe effect to the stroke.
Yeah, I think that the aortic pathology is, atherosclerosis of the vessel is affect the risk of the stroke rate. But we didn't do in this study. Maybe in the future, I may include that the data about the atherosclerosis, the plaque in the aorta, and do it more in my study.
Yes, because I think your study is wonderful and very, very good for comparison. But if you include more like a stroke, like a atherosclerosis, is maybe the better for the results.
Yeah, thank you very much.
Thank you. So we go to the next study. The next is from Dr. Titi. It's about the incidence and risk factor for the neurologic complication after TIWA. It's quite the same topic. So let's see the difference.
Okay. Thank you for the introduction, Mr. Chairman and Co-Chairman. Today I would like to discuss about my researches. This is about the incidence and risk factor for neurogenic complication after TIWA. My name is Dr. Titi Swachipong from Khon Kaen University. So I have nothing to disclose. So let's see. TIWA right now is the alternative procedure for the treatment of thoracic aortic disease. Maybe in some disease, it's the mainstay treatment for that. And from the previous study, there was a decrease in morbidity and mortality compared with the open surgery of the thoracic aorta. However, it's also associated with endovascular related complications such as the stroke and spinal cord ischemia, and also maybe require some reintervention in the future. So from the previous study, we found that there's a 3.5% of stroke rate and also 3% of spinal cord ischemia, and maybe mortality rate about 2%. So our center started perform TIWA since 2012, and there's no recent study that reported definite neurological complication related to this procedure. So the purpose of this study is to investigate the incidence of stroke and spinal cord ischemia and after TIWA, and also maybe try to identify the risk factor. So the design is a retrospective descriptive study, and we reviewed the medical record of the 104 patients who underwent TIWA from January of 2013 to January of the 2018 from the Queen's Rickett Heart Center and Sinacarin Hospital from the Khon Kaen University. And the study was approved by the KKU Ethics Committee. My inclusion criteria is the patient with aortic disease, both the dissection and aneurysm, who underwent the TIWA and also the hybrid TIWA. My exclusion criteria is the patient that has no incomplete data about stroke or spinal cord ischemia, and also the traumatic aortic injury patient because there may be some concomitant injury. So we reviewed the demographic data, the pre-operative data, the intraoperative data, and also the post-operative results. And we performed the univariate and multivariate logistic regression to try to identify the risk factor. We used the standard version 10 to use the statistical analysis, and we defined the p-value less than 0.05 to make the statistically significance. Okay, so let's see the results. First, the demographic data. In my group of the patient, is quite old. The age is about 60, and the gender is male predominated. And we also found the high incidence of the hypertension, about 70%, and also the previous stroke, about 10%, and smoking, about 57%. The pre-operative gap is in the normal range, nothing of the important here. So what about the pathology of disease? What is the main indication for the TIWA? In my group of the patient, the main indication is the type B aortic dissection, the orange size, that about 40%. The second place is the saccular aneurysm of the aortic arch. Okay. What about the extension of the disease? The extension that mostly about 67% involve the left subclavian artery. That maybe we have to perform the revascularization. We also look at the calcification of the aortic arch that may be concerned, maybe the risk for the stroke. We found that about 68% of the patients have less than 25% of the circumferential calcification of the aortic arch, like this picture. Okay? And we also saw that the main zone that the patient have to perform the TIVA is zone 1 TIVA, and the second page is zone 3 TIVA. What about the intraoperative data? The operative time is quite long, about 240 minutes. And the timing of surgery is mainly the urgent surgery, about 43%. And the length of coverage is about 200 millimeters. The diameter about 35 in the median, and estimated blood loss about 420. It's quite high because there may be some concomitant surgery that we'll talk about later. There's also the preoperative spinal drainage, about 45%. So for the concomitant procedure, we also have maybe the CABG, the ascending aortic replacement, or maybe the total artery replacement, also with the AVR or bento, or maybe EVAR also. We also have many patients that have to perform the aortic arch branch revascularization. Mainly it's the right common carotid artery to left common carotid artery to the left subclavian artery, about 47%. So let's look at the results. We found that the stroke rate is the 5 patients, about 4.8%, and spinal cord ischemia, 2 cases, about 1.9%. The intubation time about 30 hours, the length of ICU stay about 2.8 days, and the length of hospital stay 16 days. We also found the post-operative bleeding that need to have the reoperation, about 7 patients, and post-operative hypotension that need inotropic ducts in the 22 patients. The 30-day mortality is 2 patients, about 1.9%. So we performed the univariate analysis to try to find the risk factor. Unfortunately, in the first place, we don't find any risk factor that associate with the stroke, but the age, gender, timing of the surgery, the pathology, and the extension of the disease. Also, the landing zone not associated with the risk, the stroke, but we found that the calcification and the postoperative bleeding that have to have the reoperation may be associated with the risk of stroke. But after we perform the multivariate analysis, unfortunately, the result show no statistically significant result. And also for the spinal cord ischemia, the rate is too low, so we cannot calculate the univariate analysis. So for my discussion, we found that the incidence of stroke is about 4.8%, inconsistent with the previous study, and also 2 spinal cord ischemia. And the most common indication for TIVA was a type B aortic dissection. The majority of the patients had disease that involved the aortic arch branch that required to have a surgical bypass before TIVA, and the aortic calcification and the postoperative bleeding that required reoperations seems to be associated with the postoperative stroke. However, after the multivariate analysis, there are no association, and there's no significant risk factor for spinal cord ischemia to identify it. So in conclusion, we have the stroke rate and spinal cord ischemia rate that inconsistent with the previous study, and there's no statistically significant risk factor for the stroke or spinal cord ischemia after TIVA. My limitation is the retrospective nature of the study and also the low sample size. Thank you for your attention.
เอาทีถามเปล่า Yes, I think that is a good observation that you pay attention to the arc calcifications, and as per last comment, did you see the plaque or atherosclerotic other than calcification?
You mean in the CT?
Yeah.
Okay, there may be some a soft plaque that we can see, and also the calcification, but we didn't have that included in the study. Yeah.
Okay. Question from the floor? Okay. We're moving to the last presenter. Okay. So the outcome and the factors related that in the pediatric ECMO after congenital cardiac surgery by Narissaret ใช่ปะ
ครับอาจารย์ Good morning, Professor and my colleagues. I am Narisana Gabulat from Sri Raj Hospital. First, I would like to special thanks to my advisor and all of the Raj CVT staff. Today, I'm going to talk about the outcome and factor-related death in pediatrics, extracorporeal membrane oxygenation support after congenital cardiac surgery. Surgical correction leading to the injury to the heart and hemodynamic change after correction of the congenital heart disease that causes a low cardiac output syndrome. And extracorporeal membrane oxygenation, or ECMO, has emerged as an effective technique for mechanical support for bridge to recovery. Account about 1 to 5% of cardiac surgery patients. But the risk factor of death remain controversial. In this study, aim to be identify the clinical outcome of post-cardiotomy ECMO. The secondary outcome was to identify the risk factor of death between the January 2009 to December 2018. A retrospective analysis of pre-operative clinical data and outcomes was conducted from medical record. We identified that the 58 patients that need for ECMO support in Sri Raj Hospital. There was the post-cardiotomy ECMO was defined as failure to wean from cardiopulmonary bypass and low cardiac output syndrome after cardiac surgery. So we divide into two groups. We found that 15 patients in the survival group and 21 patients in the non-survival group. The patient characteristic, operative and post-operative data has been obtained. ECMO technique, all of case and we know arterial ECMO and the central cannulation, temporally sternal closure with the thoracic membrane. And all of case, we given a heparin IV drip for maintain the activated clotting time to maintain about 180 to 220 seconds. If had a bleeding problem, the ACT was decreased to 150 to 180 seconds. The continuous variable were compared using t-test, and categorical variable were using the Pearson chi-square test or Fisher exact test as the appropriate. All of this, we use the IBM SPSS statistic for analyzing data. In this figure, show all of ECMO implantation case in the Sri Raj Hospital indicated that the trend has been increased every year. When you look at the orange line, the 61.1% of case and the post-operative ECMO. And in the diagram, show survival rate over time that slightly increased. The overall survival to hospital discharge rate was 41.7%. The overall complication rate 51.4%. Liver injury 34.3%. Pneumonia 22.9%. Acute kidney injury 20%. In the AKI patient, so we have the 26.9% that needed for dialysis. The last one, 11.4% of ECMO had a septicemia. In our study, were not found the limb ischemia and cerebral hemorrhage. In this table, show the preoperative data. The male patient looked like to be survival more than female, but mean white blood cell count in the non-survival group more than survival group, with a statistically significant mean neonatal age at the operation in non-survival group are less than the survival group. Hemoglobin in the survival group are more than the non-survival group, but not have a statistical difference. But the other variable are not have the show and not show the statistical difference. In this figure, show the preoperative diagnosis. In most of cases, tetralogy of Fallot, TAPVR, and the L-kappa. The operative data table shows that the operative type, operative status, reduced surgery, cardiopulmonary bypass time, aortic cross-clamp time, or operative time were not statistically different. Post-operative timing to ECMO reoperation for any indication, inotrope dose and inotropic score. Initial ECMO flow at the ICU were not statistically different. But in the post-operative data, we found that almostly the statistical in between the two groups did not have a significant, but the AKI and liver injury trend to be increased in the non-survival group. When we look at the indication for the reoperation and death, 5 patients were reoperated due to presence of residual lesion. 4 from 5 patients will survive. And on the other hand, when reoperation with other indication, except the presence of the residual lesion, 9 from 10 patients has been dead. Only 1 patient survived from low cardiac output syndrome after arterial switch operation. In my discussion, the principle of ECMO is a supportive device that used to provide adequate blood flow for the body, and we should be waiting for the recovery of the heart. In this series, we found that the survival to hospital discharge was 41.7%, comparable to the worldwide study. And the preoperative data show the white blood cell count in the non-survival group are more than the survival group. According to the Sano study, they commented that the systemic inflammatory response syndrome are seen to progress after the deconversion. It may be responsible to in-organ damage. The strategies are used to suppress the neutrophil endothelium interaction, such as bio-coating, and minimize the oxygenator or circuit. Consistent with the Elmarak study, they collect data from 113 patients. In this study, show similar trend to other study, but not show statistically significant due to small number of patients. We should be mentioned that the correctable surgical lesion may be the predictor of the survival. When you care the ECMO patient, you must do finding of factor-related death before ECMO decannulation. So to summarize, the survival to hospital discharge rate in Sri Lanka Hospital was 41.7%. That is comparable to the international data and more preoperative white blood cell count in the non-survival group. The liver injury and acute kidney injury trend to be risk factor of death. The correctable surgical lesion may be a protective factor. Thank you for your attention.
Any question?ให้ผมถามไม่ได้เคยทำเลย pediatric. So I mean, all of the cases that put their ECMO in is from low cardiac output syndrome, right?
There was 2 indications in this study. It's a failure to wean off the cardiopulmonary bypass, and the patient had a low cardiac output syndrome.
Yes, pretty the same, but there is some patient put the ECMO from the from the OR, and some
patient from put in the ICU.
Some in the ICU. Okay. So you still use the ACT to follow the bleeding? ACT?
Yes.
Not a PTT?
Actually, in my center, we use both ACT and PDT, yes, to follow.
No more question? Okay, it's a good section. Okay, so give us time for all of the residents come back at 10:30. ก็คงจะมีตกบางคน เอาคะแนนปรับคนตกแล้วก็ไปให้คนได้รางวัลใครจะได้ 30,000 บาทใช่ครับเรามีเวลาถึง10 โมงอ๋อใช่สิเขาต้องใช้ห้องเนาะไม่เดี๋ยวเราต้องมาก่อนเราจะรวมคะแนนทันไหมครับเนี่ยไม่10 โมงขึ้นเขามีเซกชันคนอื่นต่อนะเอาน้องออกไปข้างนอกก่อนเดี๋ยวเรารีบรวมไม่ต้องกินเดี๋ยวเอามาออกไปเสียใจทีเดียวเว้ยส่งผมไฟผม3 โมงไฟกี่โมง